ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
With this brief history, I really enjoyed this video. I hope you also. It's you could see. Now we speak about International Paralympic Committee. It's an organization that covers this Paralympic movement, and this is an athlete and sport-centered organization. It's really important. It means that not a classification or something. It's important. More important is athlete. Yes, and they are responsible about 10 parasports. There are really different systems, but it's historical. You will see, this is all sports, what the athletes could do. All pictures are Latvian athletes in athletics, in bobsleigh, monobobsleigh, in wheelchair curling and wheelchair basketball. Altogether is 28, and you see 2 new will be in Tokyo, 2020, badminton and taekwondo. It also changes. For example, sailing goes out of this list. And there are, how I told, it's a different system. There are some able-bodied international federations who takes care or covers this parasport. For example, cycling, tennis, archery, and badminton. And there are independent parasport organizations, yes, wheelchair basketball, sitting volleyball. And you see others. They are independent in their decisions. Yes, in this Paralympic or parasport, popularity really increased, and you could see year by year how many participants. And of course, London was a really big event with a lot of spectators. I was in both these para games with Latvian team, but you know, in Rio was the same. All stadiums also was full. Yes, if we start to speak about a little bit gap to be and para-athlete, we could divide in non-athlete and athlete. Yes, but anyway, it is participating in sport. It's like a big tool also in rehabilitation. And there is a lot of centers where is a possibility during the rehabilitation to try different sports. I know it's in Netherlands, in Switzerland, yeah, but for example in my country it's not possible. It's like a rehabilitation and then like an empty space. But I hope it will change. Okay, here you could see it as a different titles of sport, parasport, but in 2016, International Paralympic Committee make like this one definition. It's a parasport, not like a disabled or adapted sport intent, and it's a para-athlete. But it gives also really social influence, because people also more start to take these athletes like real athletes. Okay, about athletes' identity. It's hard to start to be an athlete. This is a self-identity, social identity, exclusivity. And you see sometimes, I think it's not rare, this is a problem because athlete takes him like a serious athlete, but society no. And there's a big difference and some confusing situations. Yes, more this athlete identity is stronger for men, older athletes, and more elite athletes. Yes, and there's a lot of psychology factors. But also it could make some problems, as you see, in post-injury depression and difficulties to transition from parasport and retirement. In parasport, the athletes are not only young. Yeah, they are really in different ages, starting from 14 years till 50 something. Yes. Okay. Yes, there is two slides about differences. This is about between para-athletes who has a congenital permanent disability, and if they live a really healthy lifestyle, it's more or less bigger possibilities that they will get this athletic identity. And from another side, if they participate in competitions, they could develop it. Yeah, it's like two sides, it goes together. And therefore it's really important to make like this system for involving. And athlete identity among persons with acquired, there are like three groups you could see. First of all, athletes who identify themselves as an athlete and reject the term disability. Yes, I'm 100% athlete. Yes, I even don't think about it. Next one is a para-athletes who include para-athletes identity include I'm disabled, but I'm athlete for sure. And third group is athletes who don't try to develop athlete's identity. They all the time think how was before. Yeah, it's a big difference. Okay, about classification. You know, it's for example, all my work in parasport, also in Latvia and internationally, it's voluntary. We are in athletics. We are active 40 international classifiers over the world, and this is a voluntary job. Yes, and you see this classification is a high standard evidence-based medical system, but the main person is an athlete. Yes, and it structures the competition in parasport and gives a sports class and its status. And there is three main questions what we should answer during the classification. The first of all, does athletes have an eligible impairment for this sport? This is a decision made, for example, in athletics by World Sport Athletics. The office is in Bonn. There are really people who works and they are like employee. Others classifiers are volunteers. The second one is, does the athlete's eligible impairment means a minimal impairment criteria for the sport? It's really specific in each sport. And the third one about the class. Okay, now you could see all eligible impairments. There are three big groups: physical impairment, visual impairment, and intellectual. In physical impairment there is 8 types. You could see muscle power, passive range of movements, limb deficiency, leg length difference, short stature, hypertonia, ataxia, and atetosis. But in visual impairment, there is the athlete is assessed with a better vision correction. Yeah, it's also should be really like changes in structure. Why? And for intellectual impairment, the main point that it should be presented before the age of 18. Yes. And there is a lot of not eligible impairments, for example, pain. If during the classification the athlete feels pain, we always ask, could we continue or no? If he said he has pain, we could stop. Yes, because we need to do all tests anyway. Okay, you see others, yes? It is not eligible in parasport. Okay, everything starts with this medical diagnostic form. It looks like it's really easy. It is. This National Paralympic Committee should send it to the World Sport Athletics, and there is a special commission who estimate and say yes, it's eligible impairment or no. And after this exception, the athlete goes to next step. It's a physical assessment where we establish minimal impaired criteria. There is different, for example, in running, it's in flexion there is no any rules or points, but in extension it should be only 5 degrees. Yeah, if it's more, it's not eligible. It's like an example. Yes, and then we ask about medical history, sports history. Always start with conversation, an explanation, what will happen, training program, impairment tests, novel tests, practice activities. You know, it's easy. Actually, it's not easy for me as an emotional person. We start usually at 8 and finish usually at 9 in the evening. It's really a job, it's work, and I heard a lot of stories, and emotionally it's not easy. But for me, I find like this solution that I help para-athletes to reach their goals, like in sports medicine, and it helps me to cover it. Okay, then next one, if we find this minimal impairment criteria, we go to technical assessment, what happens in a stadium, and there we could see the warm-up, really the throwings or runnings, and then after we measure the result, it should be 85% from season's best. And then we put like a primary class, sports class, and the athletes compete. And during the competition, we should do this first appearance in the competitions, and we couldn't miss it. Only first appearance. If it's in throwing, we should do it. If it's running, we also do it in both, if athletes compete in both. And the conclusion we should put on a wall in 1 hour. In last year it was 15 minutes. It's mean decision and running to post it. Okay, about the minimal impaired criteria, it's defined in each sport. It was done by International Sports Federation. Of course, it's based on scientific research, and it's sport specific. Yes, and there is a difference. If athlete meets this criteria in one sport, it could be couldn't be in another sport. And yes, the class, there's also class not eligible. If the athlete has this class not eligible, then the second panel will, like it calls like a protest panel, will also evaluate them, starting from with a white page. Hello, how are you? What is your sport? And then if they also find not eligible, it means this person couldn't participate in parasport, of course, except if something changed in his health condition. Okay. Yes, parasport is a little bit different. There is, in technical rules, is written that they could use different assistive devices. You could see them. And it also brings an additional comment in medical care, and also these compensatory factors. Yeah, you could see, for example, in amputation, it's also influence the pelvis and the vertebral column. Okay, about technical assessment, yes, there's in a stadium, as I told you, on a field, on a track, we see warm-up, starting position, support devices, strength, stability, arm, leg movements, throwing arm, grasp, release, coordination, positioning after the throw, also balancing and and the result, of course. And then here is a Latvian athlete, Dmitris Silovs. He's now he's a world champion in class 37, but during the training they did big work with a coach, and now he go to class F38, what means he meets minimal disability. He has hemiplegia since birth, but you could see, and you see under there's all questions what we should answer during the throws. Starting position, trunk stability, arm movements. Okay. You see, everything happens really fast, and therefore there is a consent form what athletes sign. We could take video, because you see it's happened really fast, and we need to analyze and we need to describe everything what happens. Okay, And about national systems, yes, it's really important to make it because it increases people with impairment, inclusion and physical activity and parasport, and this removing social barriers and discrimination. Okay, pre-competition screening examination, we go to the next topic. It's important also for parasport. Usually it should be done once a year, like for athletes. And we do the same methods and estimate the health risks, and an additional investigation if it's needed. Okay, what we do about subjective status, it's about really good conversation. About training program, I like to really estimate how many days per week, times per day, and during of training. It helps me to understand if there's 3 days for good recovery or they are really every day. It's like important information. Type and level of sports competition, anthropometry, physical assessment, ACG at rest, and then cardiopulmonary exercise testing. The first choose is a well ergometry. If it's not possible, treadmill. If it's not possible, arm ergometry. Okay, and then analysis and also risk factors and additional investigation. This is not about para-athletes, this is about master athletes, veterans, but this is a good research which show this value of arm exercise testing, and you could see this metabolic units and the maximal heart rate, maximal exercise systolic blood pressure. It's really connected with risk assessment. Okay, exercise capacity. It's really important because we could do training planning. It helps also for coaches and also explanation for athletes because they are adults. They understand what they should do. And this is how it looks like. This is my system. I do it every day, not only for parasports. I work with national teams and for amateurs and for professionals, but also for para-athletes. Okay, cardiopulmonary exercise testing. I estimate health indices, functional parameters of cardiovascular system, respiratory system, and evaluation of physical working capacity, recovery, changes in ACG, adaptation, and at the end, sports medicine recommendations. But it's the same as for athletes. And this is one of the important slides. If we allow to participate, we should understand that athletes could participate in very high intensity level without any limitations. There is not like a partly or something. Yes, this risk estimation. Therefore, I like that this screening should be done like some 6 months before. If there's some problem, we could manage it. Okay. Yes, about wheelchair sport. This is really specific, and there is like 3 factor groups. First of all, para-athlete, anthropometry. There's a big difference, like in sport. Weight, height, limb length, and also physical factors, gender, disability, skills, experience, and age. And also about wheelchair mechanisms, configuration, and design. It also gives influence. And we continue. Ergonomics of sports. It's about, actually it's about technique, how the para-athlete can use really his possibilities, and also racing chair. Okay, medical care, yes, should be related to sport specific, because different kind of sports have higher risk in one, for example, injuries or health problems. And also para-athlete is the same, like athlete goes under the rules of world's anti-doping code. Yes, and but sometimes if they have some injury or diseases, it's possible recovery will be, or rehabilitation will be longer than it usually. Okay, because under it is this pre-existing medical condition, And you see these different health problems, what could be, and we should think about it when we take care about athletes, or when we go somewhere. Yes, and now about illnesses, you see in summer games, you see the numbers in percentage in para games, it's higher than in Olympic games. Maybe it's understandable. And this illness incidents, it means Athletes Day, I put like an example, if there is 2 athletes and they compete 3 days, it means 6 Athletes Days. And you could see in London, in the summer games, it's less than in winter games. And about the organ system, you could see also the like a difference between summer and winter games, but respiratory system is a main point. Because I remember in Rio we also has this problem with conditioning. Yes, because in our country actually we don't use conditioning because the weather summer is mean 23 degrees, but in hot countries there's like a big difference, and our athletes are not ready for this. And yes, about this intrinsic risk markers, you see underlying unique medical problem, because every para-athlete is different. This is a different impairment. And extrinsic, what these factors we could change and be ready, but it means that we need to know the environment. We need to plan traveling, and also training program and food. And we have, yes, I put in this problem if food is accessible in 24 hours. Yes, we have this problem in both Paralympic in London and Rio. For some few athletes, they go to eat also in night time. If they have competition after 10 days or 7 days from the beginning, it could be a little bit problem. Okay, about the traveling. The first point that sports medicine doctors should be in good fitness, because we always need to help. We always need to bring something, to hold something, but not overstep the border, because para-athletes would like to be independent. Okay, regular medical screening. It means that we know our athletes. Planning of medical support, knowing the destination. For example, when we go to the Rio, I gave a small lecture for athletes, how to be ready. We also did vaccination and different actual things. And yes, personal hygiene is important, and early isolation if there is symptoms. This is a research about London, and you could see the difference also between summer and winter games, but again about in winter there is more athletes. I think there is not right, it's injury rate, but it's a illness rate. Yes, but this is not dependent of age or gender. Yes, in first place is a respiratory infection. I think in a sport it's like in a parasport it's the same. And also about the skin and subcutaneous tissue, because there is a neurologic problems with sensitivity. And for example, in Rio, I do for 2 athletes every day take care about their skin. It's like additional duties. And there is a report about illnesses in summer games. It's depend on impairment type. Yeah, you see the spinal cord injury athletes are more than in deficiency because of the skin problems. Yes, and then is visual impaired athletes. Yes, in parasport the same, female athletes in this triad. Also important, also we estimate. Also, we speak with athletes, and this, yes, this bone density, it could be not only for female but also for male. Okay, the prevention, yes, manage training load. It means good cooperation with sports trainer, adequate recovery, proper hydration and water spray. Yes, it's always used by athletes with spinal cord injury. Appropriate clothing, good hand hygiene, nutrition intervention, aseptic catheterization, skincare, and well-fitted prosthesis and sockets. Okay, in nutrition, I think for me, like, because I work with the para-athletes and non-athletes, it's like the same, but also I should take that information about the para-athletes. But anyway, this individual and personalized planning, and we should take in consideration all these factors. Okay, about supplements. Yeah, in parasport it's a really high prevalence of supplements use, and in Latvia, Latvian Paralympic Committee made the decision that now they covered all expenses about supplement, what I accept, because I'm a Latvian Paralympic Committee sports medicine doctor, voluntary, of course. But anyway, but it means that we could also like follow this anti-doping code. It's better. Okay, yeah, you see. But sometimes they use a lot, and they use cocktails, and there's a different ingredients, and it's really hard to explain. Okay, about prosthetics. This is a one run. You see, there's a difference. There's in some competitions, different classes are put together, but you could see on athlete on the on the right side and on the left side, they are in the same. Not now, but before until the last year, they were in the same class. The left side athlete has neurologic problems, and this athlete has amputation. Let's look how it looks like, and also what could happen during the race. Yeah, it happens, not often, but it happens. They couldn't stand in one place. They always need to move. Okay. Okay. About prosthetics, there is also some more often problems, the stress syndrome, overloading, pain, because because skin is not so strong. Yeah, it's not like in a food. Pain and reduced sensation, longer healing and regeneration, and others. And treatment, yeah, the main point is the skin care. Yes, good hygiene, clean nightly. Change the stump, sockets possible, and wash as soon as removed. It's really important. Each skin lesion is very important, because if we don't treat it, it could take athletes out of the competition. Okay, but it's not good, or yes, it's not good to use these needles or something, but could also change the skin. Okay, and yes, you see the methods for the pain management, but it's sometimes it is complicated. Okay, this is one research because not usually, but sometimes these para athletes or person with disability, they like a side of the physical activity and sport. And there's really a big difference between this, their VO2 max and aerobic threshold maximal another measurements, but treatment, endurance, exercise treatment. And you know, they could value and they could increase their injuries. Yeah, you see this about London. If altogether in athletics compete 977 athletes, injured was 216. And this incidence proportion is enough high. Yes, and incidence rate also. But they compete with complaints because they are really motivated. Yes, you see a lot of athletes only had 0 till 1 missed day. And impairment types of injured athletes, you see, this is about impairment types, how many injuries. In first place is ambulant amputee, next one is visual impairment, and cerebral palsy. Yes, and also in parasport, the same as in sport, each kind of sport has more often injuries. Okay, thank you.
Thank you, Sandra. Any questions or contributions from the audience? I have a question, Sandra. How do you classify in the same sport but different level of disabilities?
Mm-hmm.
Is there any classification, the levels of the athletes in the same sport?
Yeah.
When they are competitors?
Yes, there's it was historical when the classification happened after the level of injuries.
Yeah.
Now it's more or less like a functional. Because the emergency medical care is faster and it's a better treatment. And for example, spinal cord injury not always are full, and there's a big differences. Every athlete has a different symptoms and different functional status. And then there is like some borders, and there is description in each sport what this athlete could do or what he couldn't.
So they can compete in same level.
Yes, yes.
According to this classification.
Of course, some athletes has disadvantage.
All right.
Yes.
All right.
Okay, thank you.
Okay, thank you. Now we can move to the next session. Please, William Roberts. The title of this session is Team Matters, Prevention, Care and Recovery. Earlier. Or we can wait some. It will start this session at 9:40. Actually, we have time. We can expect more participants anyway.
Yes. Okay. I think this is the movement session.
This one?
This one, yes.
Yeah.
They're coming, some ladies, and then we
It will be at 10.
we should, yes, we should, no, we should wait. Okay. You see.
Because we have to sit down and session.
Okay, they will cut my session.
After the first session, after the first talk, after your talk.
Okay. So we can start. So what are we doing? Yes.
Expect some more participants.
So here's our things. We don't need to introduce me.
Yeah.
So just see
Pediatrician.
those things. this will take all their time.
Okay. This first session, first 30 sentences.
Yeah.
That's it.
Han,
Okay.
Vincenzo, Just think of it like Hawaiian. You have to say every letter.
Scientific commission.
Okay. All right. Probably that first sentence there. Oh, maybe put this in just to advertise the next EFSMA.
Yeah.
Probably just the first sentence.
Okay.
All right, so it's Eva, Anu, Vincenzo. Okay. I'll move down there during this session so I can see the slides. Otherwise I get a really stiff neck. Do you go home today or tomorrow? Me too. We'll fly to the office, so take the shuttle to London. 8 o'clock. We leave, but we're leaving here right after this, after the Congress closes to Ljubljana. Then we fly Ljubljana to Amsterdam, Amsterdam to Minneapolis. I'll be tired on Monday when I have to work. Okay.
Are you working on Monday?
And I jump right back in.
I'm flying to from 2 hours from India to Istanbul and then to early in the morning I have to Monday.
Yeah, no rest.
Rest is afternoon and tomorrow.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
Good morning. This is a session on team matters, prevention, care, and recovery. Main Jürgen and I'm Bill Roberts, will be moderating, and our presentations are all 20 minutes. We'll try to end at 11 to get you out to the break. Our first speaker is Peter Schober from Austria. He's a pediatrician specializing in neonatology, pediatric intensive care, and sports medicine. And his topic today is your athlete on the verge of overtraining. Peter.
Good morning. Dear Chairman, ladies and gentlemen, I try to give you some facts to help you to decide this topic. First we are looking about the influencing factors of athletic performance, and you know it's the cardiovascular system, the musculoskeletal unit, strength, endurance skills, training, competition load, fluid and nutrition. And I think the most important thing we have to look in this topic is the regenerative capacity. What's about the immune system, the sleep, and the psyche. And the influencing factors are first the load, the methodical control variables. I mean the types of sport, types of training, and training content. And this load will make a stress and reaction of the organism. We can measure the heart rate, the lactate, the stress hormones. We can measure the problems to the musculoskeletal unit and especially also the brain. And this system is also influenced by the amount of mitochondria, I mean by the level of VO2. And these all are the factors, they can influence the regenerative capacity. And there is another fact influencing this system. It's intensity of training. And you can see this Yakolev scheme where you have a training load and then you have a super compensation. But it's different in different intensity. So you see that you can improve the performance, the VO2, but also the recovery time is prolonged. And this is a very old paper, but I don't think that many physicians do know. And what we can see here is influence of intensity on stress hormones. And you can see if the training intensity is high, and you can see here the lactate fitting curve, it is identical with norepinephrine. So high lactate levels have also high norepinephrine levels. And if the intensity is moderate, you have the right shift, and it corresponding to this, the stress hormones are high in this case and with a long recovery time, and in this case the stress hormones are low with short recovery time. Why it is so important? It is the influence of intensity on mitochondria membranes. And the destruction of this membrane at lactate levels in percent, you can see up to a lactate level to 7 millimole per liter, you have up to 3%. 8 to 15 millimoles, you have 5%. And in this intensive we have up more than 7%. So too frequent high intensity with too short recovery time can impair or even prevent the training effect by destroying the mitochondria membranes. And when we have a look at the cellular pathophysiology on exercise, then we have first, and we need this, the muscle cell damage. And then dams were generated. It's damage-associated molecular patterns with mitochondrial DNA, heat, shock proteins, and formyl peptides. And they attract in the immunocells, macrophages, granulocytes. And these are producing cytokines, pro-inflammatory and anti-inflammatory cytokines, and the result is an inflammation. But the myocellular recovery is in this state is working, but if the muscle cell damage rises, then this recovery won't function. And then we have a marked inflammation. And this inflammation has influence on the immune system. And I will show it you in the sepsis model published with these men. And you can see we have pro-inflammatory cytokines with tumor necrosis factor and interleukin-1, and anti-inflammatory cytokines. And these cytokines are only expressed in moderate, when you train in moderate intensity. And the other one, in high intensity, you have pro-inflammatory cytokines. And they are influencing your immune systems. And if you have an inflammation with high susceptibility to infections, and you know, especially in winter, when the endurance-trained athletes are always ill with several infects of the pulmonary system. And why does this happen? You see, we have an influence of stress hormones on this regenerative capacity. And our body, in our body, we have circadian rhythm. You can see the body temperature, and we can see the stress hormones. And if you have a look at the night, then you see growth hormone and melatonin is expressed. But, and you have a very low, we have a high parasympathetic and very low sympathetic. But if the sympathetic and the stress hormones are high, especially cortisol, then no growth hormone is purged and no melatonin is produced. So the regenerative capacity is low because we don't have anabolic hormones. So lack of recovery is influencing overtraining syndrome and also injury. And I will show you some slides. Here is a triathlon professional with a training amount of 24 hours a week with an adequate performance and an optimal heart rate variability. And you can see this, they are really regular columns according to the REM phase, and a very, very strong parasympathetic. Then the coach decided the training amount should be 30 hours a week, and also the intensity should be higher. And the result is it was no development and deterioration of performance, and also deteriorated HRV. And you can see the columns, they are not here. And also the parasympathetic is not really here. And the result was an overtraining. And you can, with this device, you can see what happens. You can see that this an analysis, and you can see there's a training response. There's also a training response here, and here, and the capacity was 65%, and then rest, recovery, and up to recovery to 115%. So you can see this this influence on HRV. Do you know some soccer coaches who guarantee for muscle injuries? Maybe you know the same than me. And it's training frequency and especially training intensity. I will show you. And I show you two very interesting papers. The first is from X-Trend, time trend analysis in total hamstring injury rates showing a significant annual 2.3 increase over a 13-year period. It's the black curve, and the moving average approach indicating 2.2 yearly increase is the gray. So you can see that there is a connection between load extent and especially high intensity interval training. And the next paper, Gabbett mentioned the training injury prevention paradox. Should athletes be training smarter and harder? Polarized training. And you can see in this paper, he figured out the sweet spot with a low injury risk and the danger zone with a high injury risk. And regarding to acute and chronic workload ratio, he mentioned to minimize injury risk, practitioners should aim to maintain the acute to chronic workload ratio within a range of approximately 0.8 to 1.3. It's really necessary to take this in account. And why we have so often problems with the muscle? This is the influence of intensity on muscle and fascia. It's a very good paper from Schleip, and he figured out that the fascia before intensive exercise is smooth and elastic, and after intensive exercise it isn't smooth, it's hard. And what happened with the muscle? The muscle glycogen is diminished, it's a depletion. We have a diminished ATP synthase, the stiff muscle, the shortened fascia. And the papers figure out that the normal elasticity of the fascia are about 4 centimeters. And if the fascia shortened, then the probability for muscle rupture, muscle tear, is about more than 80%. So the shortened fascia is one of the main factors for muscle tears. So we can say intensive exercise is responsible for dysfunction, for fascia shortening, muscle and joint problems. And I show you another slide. This is a swimmer, an athlete. It was the vice European champion, and you can see we made some investigations in strengths, and you can see that the development with a computer assessment, and you can see that the development is very, very good. And it's about 265 watts per kilo. And then it was a period of 14 days. And you can see that there's a decrease of more than 60 watt per kilo. And what was the reason? The reason, the coach is a very, very famous coach, but he didn't care about this, what I has to tell him. Okay, but what happened? Intensity, especially regarding to strength endurance training, was markedly increased. So there were time for recovery for 4 weeks to the qualification run. But you can see that he couldn't reach this result, and he couldn't qualify him for for the European Championship, and because of the overtraining. And I showed you another slide regarding to our ÖSV, our ski alpine team. It was the Styrian country's junior squad, and the aim was training recovery in the height, and the coach default were 4 runs, giant slalom with maximal speed. The place was Olpera and at the Hintertux Glacier, and you see it is a very high training. It's a high training situation. And then I told the coaches they should rank the athletes, and they should give me the time, and you can see, and then I edit, and you can see that there is often do not finish. And then I put our measured VO2 inside. And you can see there is a cutoff point of 55 milliliter per kilo, per minute per kilo. And you can see also that these athletes are able to perform also in the 4th run. And this was Klaus Krell. He was the later world champion in downhill. And so it's important to have, if you have a training in height, you have to have enough VO2, otherwise you won't recover. And this is an Austrian tennis fate. It was a junior world champion. And we investigated the performance development in sports, motor skills, speed, power, VO2, and this is the sum of these results. And you can see then the coach decided training intensity is increased, aerobe basics decreased. And then he was in the National Training Center, the training intensity was more increased, and the coach at this time was Presnik. He told me, no, it's not necessary to train endurance. So the aero basic were complete, more or less stopped. And you can see, despite their training sport, motor skills, speed and power, they won't increase these abilities. But and you can see that the VO2 comes down. So what happened? This athlete, this junior athlete, had a wrist injury and an operation, and it was the end of career. So this was, for me, it was really a pity. And I give you a small hint about overtraining, stress, and brain function, and I show you the normal pathway in the metabolism is tryptophan, which generates serotonin and melatonin. But if you have stress and inflammation, then you have elevated cytokines. And these elevated cytokines, there is the IDO expressed, and this express it generates kynurenine, and kynurenine has a neurotoxic effect and inhibits tryptophan transport to the CNS. And you will lose your executive brain function. So the athlete won't care about their bodies. And you are able to get a burnout and the depression, and also in the I think it's in the severe case, suicide. So, in summary, I think you have to think about on overload or overtraining syndrome first on clinical syndromes. It's a stagnating, deteriorating athlete performance, increase of pulse and blood pressure, stress, chronic fatigue, anemia, negative nitrogen balance, and muscle and susceptibility to infection. So I'm finished. This my younger son forced his old father that he should, again, after 14 years, I had a severe injury to surfing, and you say, here on the hook, but my stress was only very short. Thank you very much.
It's energy shot time. Thank you for the presentation. Exercise leader for that energy shot. Our next speaker is Eva Martos from Hungary. She is MD, PhD, and head of the Center of Sports Nutrition Science at the University of Physical Education in Budapest, Hungary, and she's now responsible for organizing the next EFSMA meeting in 2021, which will be held in Budapest. Eva.
Thank you. Dear colleagues, first of all, I would like to thank for the organizers to inviting me, especially to Petra Zupet, to talk you about this very relevant topic, the relative energy deficiency syndrome in young athletes. In the following minutes, I would like to talk you about the definition, its health and performance effects, about low energy availability, prevalence, diagnosis, and rather prevention than treatment. What is REDS? The term relative energy deficiency in sport refers to impaired physiological functioning associated with negative impact on health and performance. REDS has a wide health consequences especially because the impaired physiological functioning includes impairment of metabolic, endocrine, menstrual, cardiovascular, immunological, psychological functions of the body. You can see here in the red triangle, the triad, but REDS concept expanded the triad syndrome. As you know, triad is the interrelation of disordered eating, amenorrhea, and osteoporosis. But this concept reflects a wider range of outcomes. Health consequences of RED can be particularly explained by the disruption of the endocrine function. These include the disruption of hypothalamic, pituitary, and target organ axis, alteration in thyroid, in adrenal gland functions, and apart from these, there is changing in appetite regulating hormones and of insulin. What about the effect of performance? As you can see, there are minimum 10 kinds of negative effects of REDS on performance. It is caused, an impairment of training adaptation is caused by REDS by decreasing glycogen store or protein synthesis. Impaired recovery might be also associated with reduction in physical, psychological, and mental capacity and increased risk of injury. This increased risk of injury prevents participation in regular training. According to research data, a high-level artistic gymnast will miss due to injuries up to 21% of the total annual training, which means approximately 2 months. The etiological factor of REDS is so-called low energy availability. What is it? Low energy availability is a mismatch between energy intake, diet, and the energy expended in exercise, leaving inadequate energy to support the functions required by the body to maintain health and performance. We can calculate energy availability. Simply, the definition of energy availability is the remaining energy for fundamental physiological functions after subtracting energy expenditure of exercise from energy intake. And in the equation, it is adjusted for fat-free mass. This figure illustrates the energy availability concept. Optimally, as we can see in the middle of the figure, energy derived from dietary intake covers the demands of training and the remaining energy. In the middle, this optimal situation is shown. The energy intake is sufficient to cover the demands of training and also fundamental life processes to maintain health. On the other side of the figure, this is not the case. Low energy availability is a situation of insufficient energy availability to cover basic physiological demands. The low energy availability can arise unintentionally and intentionally. On the left and on the right side of this figure, you can see that the energy available for life processes are less here and also here, are less than in this optimal situation. Here is intentional law, which means that energy intake decreases, but the energy demand from daily training load is the same as in optimal cases. On the other hand, here is the energy intake is the same as in optimal cases, but the energy demand for training load, that is the intensity or volume or both, increases, and that's the main reason for the reduced energy availability for vital processes. We can classify energy availability levels. There are three categories. First category is when everything is okay, the energy availability is optimal. And then the so-called subclinical category, it's from 30 to 45. This equals to the 30 kilocalories equals to the resting metabolic rate. And low energy availability is defined as less than 30 kilocalorie per kilogram fat-free mass. There are several predisposing factors of low energy availability, but this can be put in two main categories which were already mentioned. There is the so-called intentional, mainly it's accompanied with restriction of food intakes, and it occurs particularly in weight-sensitive sports. The main objective in these sports to optimize body mass or body composition for competition. This intentional includes restrictive eating, fasting, skipping meals, using diet pills, laxatives, and so on, and it can progress to eating disorders. On the other hand, unintentional it's mostly in endurance sports, when high training load is associated with unintentionally inadequate nutrition intake. It can be caused by suppressed appetite, lack of time for eating, poor adjustment of training and fueling, inappropriate nutritional knowledge, and other reasons such as popular diets, low energy density foods, or extreme fiber intake. May I highlight the sport-specific risk factors for eating disorders or disorder eating? These are early start of sport-specific training, dieting to win or to be thin, sudden increase in training volume, overtraining, injuries, pressure to reduce body weight or change body composition, chronic dieting, weight cycling, perfectionism, and over-compliance. What about the prevalence? The literary data are very inconsistent, mostly because of the methodological differences. But more common in females, but males are also affected. I mentioned that REDES concept is in REDES concept, female athletic trial was expanded for another 8 or 10 outcomes. And the reason was, one of the reasons for this was that this redness could be observed not only females but males also. In males, mainly cyclists, rowers, runners, jockeys, weight class sports are affected. In elite middle and long distance runners, about 31% of females and 25% of males are affected, but there are several prevalence data in the literature. Aesthetic sports are also highly represented mainly in women. Prevalence increases with competition level, and LIA may start at young age. What about the prevalence in young athletes? The data are more inconsistent than in adults, but females are at greater risk than males. Many young athletes develop of redness with or without disordered eating. The prevalence of 30% in male and 50% in female athletes has been reported, but yesterday, for example, we heard in the presentation of Professor Steinacker a much higher prevalence data than you can see here. The prevalence of the disordered eating is high in competitive youth sports, with the peak onset of eating disorders coinciding with sport specialization and increasing in demanding competition. What are the special considerations in young athletes? There are special considerations, but all these factors can be associated with growth and development. The energy required for growth and development, the achievement of positive energy balance during this period, and nutrients that have particular impact of use, like protein, calcium, vitamin D, iron, and zinc, all have to be kept in mind and in focus. Prevention is crucial because the earlier eating disorders begin, the longer they might continue. And now I would like to introduce an example that highlights the risk factors associated with relative energy deficiency during growth and development. I was at this time the team physician for the Hungarian Olympic gymnastic team. Therefore, I had an opportunity to monitor the body composition and the eating habits of them. May I focus on the weight and body fat percent of this gymnast. The energy intake seems to be very inadequate to cover the energy demand of the daily 6 hours of training. The energy intake of 4 gymnasts was less than 1,500 calories. As I mentioned earlier, calcium and vitamin D have a special role in young athletes. Adequate calcium and vitamin intakes need to maintain optimal bone health, well below the national recommendation. Iron has also an utmost importance because of hematological function and menstrual function. The gymnast team iron intake was well under the recommended 50 milligrams. 30% of the team had prelatent or latent anemia. Optimal zinc intake plays also an important role in immune functions, but the intakes in this case didn't reach the national recommendation. Since red has so many effects, both acute and long-term on health, early diagnosis has a key role. The diagnosis of redness could be easy in theory, based on the equation presented earlier for the calculation of LEA. but there are several methodological concerns for the accurate measurements of all three components of the equation. Just mention a few. For estimation of energy intake, there are several methods. For example, photography or 3D food records and others. But in most cases, especially in weight-sensitive sports, underreporting the energy intake. Or in case of exercise energy expenditure, also we have several tools, but especially, for example, wearable devices, but they may over or underestimate energy expenditure. And even in fat-free mass measurements, there are several tools available, but most of the methods are not standardized. Screening tools that are suggested to use in the diagnostics of REDS includes, for example, pre-participation examination. May I mention here that the Hungarian Sports Medicine Association implemented just recently 10 relevant questions in the pre-participation questionnaire for the early recognition of REDS. There are other possibilities to diagnosis, anthropometric measurement, there are specific questionnaires, personal interviewing, and several hormonal and other biomarkers. Risk assessment is very important, and the treatment depends on the degree of the risk. You can see here the so-called risk assessment model for sports participation. This was introduced in 2015 by IOC, and you can see 3 categories. In the first category is no start is allowed for the athletes. And it means that they have to sign a contract and so on and so on. And in case of low risk, there is a green light. Prevention is very important. I think raising awareness is the best buy tool for prevention. You can see a very good example of the British Association of Sports Medicine spreading knowledge and information about REDS. Education is the other very important tool. It's another website dedicated for REDS by British Association of Sports and Exercise Medicine. Because there is a disordered eating continuum for health to the disease. Therefore, it's important to cut the progress as soon as possible. There are several consequences of disordered eating if we don't cut the progress. In this case, these consequences arise. This could be delayed pubertal development and retarded growth, imbalance of bone remodeling and amenorrhea. This prevents achievement of a high peak bone mass, and disordered eating behaviors. I think it's also a serious consequence, might be sustained and tracked to the adulthood. The intervention strategies is teamwork, a systematic screening, individualized dietary plan, including energy and nutrient supply, should be periodized to training, competition, body composition, with highlighting injury and disease prevention. And targeted micronutrient supplementation is also important when needed, and especially in case of unintentional decrease of exercise intensity or volume, it's also important. Cognitive therapy can be used, and I think the last sentence you should take home, that losing weight is generally not recommended in young athletes below 18 years of age. And this was my presentation. Thank you for your attention, and I'm delighted to invite you to welcome in Budapest in 2021. Thank you.
Thank you, Eva. We're running a few minutes behind due to our energy break, so I think we'll hold questions till the end. Our next speaker is Hannu Koki. Koke. My apologies, my pronunciations aren't the greatest. Hannu is an associate professor in anesthesiology and in intensive care medicine at the University of Eastern Finland in Finland. And his topic today is recovery after exercise and injury. Why is topical menthol superior to ice bath?
Mr. Siemens, ladies and gentlemen, good morning, and it is great pleasure to be here in Slovenia, second visit here, and I have really enjoyed. It is not only the hard training, but also the recovery. And coming back to Mr. Siemens' presentation yesterday, I'm not sure whether all agree that physical activity and health-related benefits are linearly related. I think quite many think that you can even overtrain, and thus the recovery is as important as the training we have heard this morning. I have one potential interest in this. I give some medical consultation for Visualize Fest that runs some exercise centers and gyms in Finland, and Ice Power is produced by Visualize Pharma that belongs to the same companies. Menthol and ice are two crucial natural products, but they are distantly different. And we know since 2002 that menthol acts on TRPM8 channels that can be activated both by tissue temperature of 25-28 degrees or by menthol that is counter-irritant. So initially menthol stimulates the channel and then desensitizes. And as menthol is highly lipophilic, it is absorbed within few minutes after application to skin. Ice bath or cold water immersion is a form of cryotherapy. Temperature are much lower than where the TRPM8 is activated, so it activates a totally different receptor. And as you see from the picture, quite many describe it not that pleasant. And during the last years, there has been increasing number of publications indicating that maybe cold water immersion is not that benefit. When you go after a single session to cold water, it releases your endogenous opioids, and with opioids you get high and it feels good, but for long-term adaptation for exercise, it is not that good or can be even harmful and decrease the exercise response. It has been shown, for example, in sprinting training where post-training treatment with ice has decreased the level of anabolic hormones, growth hormone, testosterone, and the response to training is significantly less than with active recovery without using ice. On the contrary, there are several randomized control, active control and placebo control trials indicating that topical menthol is superior, for example, ice pack when high school students train hard and came back with sore muscles 2 days after the training. The pain was significantly less after applying topical menthol compared to the day when they had the ice pack on sore muscles. Muscle soreness was significantly less, and the tetanic force they were able to produce with the muscle was 2 times higher compared to that after using ice on the sore muscles. There are experimental data, but also human data that topical menthol can also improve endurance training response. And now, 2019, we know that TRPM8 receptors are expressed in muscles, and as we heard this morning, mitochondrial function has important role in endurance training, and it seems that this is based on the activation of mitochondrial function during the training session. It has been also shown in very elegant studies putting a lower limb on the frame where you can activate only the quadriceps muscles, and again placebo-controlled randomized crossover study where they show that applying menthol gel to the quadriceps muscle 15 minutes before the test, the people were able to produce significantly more muscle strength than when applied placebo gel. And no one from Slovenia, are there any? You are from Slovenia. You play volleyball here also. Do you play? Yeah, but in Slovenia. You go also to world champion. Yeah, I think in volleyball it depends how high you can jump. And this trial, they do hard training every single day and treat the muscles either with menthol, either with ice, or have the control group. And the menthol, the high jump decrease also in the menthol group, but in the ice pack and in control group, it decreased significantly more. And I think at least in world champion, 2 or 4 centimeters difference means a lot, and they have also an agility test on that and the difference was 0.2 seconds in 10 seconds agility training. Interestingly, we have got those TRPM8 receptors also in blood vessels, and this is why when we apply menthol on skin and when it has been absorbed in 15 minutes, it actually causes vasodilatation that is contrary to ice. And this has been shown also in several studies, and there's an example of where they put those probe on a few centimeters deep on the muscles. And in the menthol group, the blood circulation increased after 15 minutes and then last up to 60 minutes, while in the control group it stayed more or less the same, and in the ice pack group it decreased significantly. More serious results have been reported in surgical patients, where after applying those cooling system on the skin and after the cessation of the cooling, the vasoconstriction lasts several hours. So when we stop and let the passive rewarming of the tissues, the vasoconstriction lasts, and so you don't bring those growth factors and other issues on the plane. And when we are here in health, business and exercise, it has been shown that ice bath is associated with increase in arterial blood pressure. And in contrary, based on that we have those TRPM8 receptors in our vasculature also, using topical menthol, we can avoid or at least attenuate cold-induced hypertension that has been also recently shown quite elegantly. And in sport-related injuries, the lunge-making papers Iraxinen are study from 2008 where they show that topical menthol is highly effective for sport-related soft tissue injuries. It was superior compared to placebo. It was effective and safe, also no disability. So the people in the active group on menthol gel group recovered to the same level as people in the placebo group in 2 weeks, and after 2 weeks use of topical menthol, the recovery had been similar than in placebo group on 4 weeks. And I think this means not only for athletes, but also our rehabilitation patient. And just recently it has been shown that also after surgery, topical menthol improved recovery after major knee surgery significantly. And it should be said that use of ice on acute injuries has not been proven in any randomized clinical trial. And there's increasing number of data indicating that ice can be even harmful. And for example, Usain Bolt, when he got muscle cramp on his thick, they didn't put any ice pack on there. They just had a fair share for Usain Bolt. And actually it has been shown already 1991 that actually any prolonged use of ice can increase bleeding. Actually we can jump this over. And the RISE principle was coined by the Kate Mergen in 1978, and even Kate Mergen has changed his opinion now 40 years after that. That at that time it was not evidence-based medicine, and now when there's increasing of evidence on harmful effects of ice, he also says that it keeps healing cells from entering injured tissues, and ice reduces strength, speed, and endurance and condition. So I think it's time to leave the back the RISE principle, or at least the ice from the RISE principle. Compression may be, and elevation may be useful still in 2019. And there has been several authors saying that is the ice bath finally melting. We have got those ice piers in Finland, not pingvins. And Mr. Seaman, why is topical menthol superior to ice bath? Just simply because it is evidence-based. And there's increasing number of data indicating that topical menthol can enhance and hasten recovery after musculoskeletal injury, whether we have caused them by ourselves or our surgeon friends has done it. And if we apply topical menthol 15 minutes before and after training to muscles, we can enhance the recovery, improve training response, and for example, decrease delayed onset muscle soreness. Thank you for your attention, and would be happy to answer any comments or hear any contradictory arguments on this issue.
Thank you for a very interesting presentation, and for an old guy like me who started practice around the time that rice became the sort of the byword to treatment, it's been a difficult transition to move away from ice for me, but that's what my lectures talk about now, is moving away from ice and toward other methods. I hadn't reviewed the literature on menthol, but this is very interesting data, and I think something we should think about in the future. So thank you very much for the presentation.
You can use ice any short periods, but be aware, and better to measure the tissue temperature if you use ice also. Any longer application or repeated application is not that wise. Yeah, thank you.
I agree. Thank you very much.
The next speaker is Professor Vincenzo Ierasitano from Italy. He is the medical director of the national rugby team since 1995. He is also a member of Federazione Medico Sportiva Italiana, and since 1998 he is a member of the medical board of the International Board of World Rugby, and he is EFSMA Scientific Commission member. Ready? Okay, please.
Thank you, Mr. Chairman. It's a great honor to be here. Let me say thank you to the two presidents of the Congress, Petra Zupet, my new friend, and my old friend, Maurizio Casasco. Speaking about emergency, in my old playing time, means sometimes to have available as a pitch side a bucket with water, a sponge, and something else. To carry out of the field, you use sometimes this kind of very improvised stretchers. But today, looking around what's happened on the sports fields is not very different. Have a look. This should be a safe extrication. Was a big violence on this player. Right? And in this situation, even for a cardiocirculatory disease or for a traumatic disease, look at the hyperventilation should be the topics, but after a few minutes, they let players fall from the stretcher. And this is either Real Madrid, with a bleeding wound and no protective equipment are used. So no good education from the television. This is an interview from a player that could help, would help this traumatized goalkeeper, and look at this. This is the final result with a big problem, could be a big problem for his neck. Finally, this is one of the match in the Brazil World Cup, is a fracture of vertebral fractures. Look how this is assessed. No immobilization. And now look the transport. Very dangerous, very dangerous. Anyway, in the time in which everybody of us try to make a bigger, faster, stronger player and athletes, now the need was evident to create a recommended guidelines for freestyle sport during competition, but above all during training. So borns the PSSD of Federazione Medico Sportiva Italiana. What is the educational program with the guidelines built in cooperation with the ICE Institute of Health, Istituto Superiore di Sanità, is intended for the sport operator education. The program has been studied thinking the specific sport risk for each sport discipline. Federazione Medico Sportiva Italiana stresses the need of introducing the sport world concept of specific risk evaluation that is which is possible to interview appropriately on the playing field. The main goals is the management of a cardiorespiratory emergency, the management of catastrophic sport injuries, above all concussion, in on-field assessment, in emergency room assessment, and the good transportation. Taking some example from American College of Surgeons Committee on Trauma, we change the words, the pre-hospital management during the golden hour in the golden 10 minutes, the golden 10 minutes immediately after the trauma. No definitive treatment can be provided only off the player field, but begin in the playing field with the no-hospital management of trauma. Looking at if we have to assist swimming game is one thing, but different if we have to assist a competition like that, in which could happen injury like that, and you should be very good educated, organized, to do a ready mobilization, a proper assessment, a correct extrication, and a good transport. So understanding the common mechanism of the injury and the sport-specific risk as part of a prevention strategy is critical in caring for athletes. In this bicycles competition, the specific risk is due to a very demanding stage or due to a very crowded stage. That means a different kind of organization for this competition. Now, the education of the medical staff means doctors, means physiotherapists, means everybody around the medical team is very compulsory. This is the rules in the World Cup, Rugby World Cup that is now in Japan, and where the term medical staff have to comply. ECO level 2 is immediate care for rugby, now is and the course of PSSD is the only non-language course that is approved by World Rugby, for instance. This is the classification of sports and based on risk. But still, even in the low-risk competition could happen situation with the ankle strain, and follow that, dislocation of the shoulder. So must be ready, athletics, soccer, other second no contact sport, but still dangerous for days, and we must be ready to assess that. Even these very gentle, very elegant sports, but could happen during a pirouettes, to knocks and bleeding wound on the face of these girls. And also due to obstacle. Obviously, the third class of risk is contact or collision sport, like rugby, like boxing, like car race, horse riding, very dangerous for the neck injuries. Now we speak about organization. The availability of the defibrillator or other emergency device doesn't guarantee by itself an efficient emergency system. It has been demonstrated that emergency devices have been included in a security plan. This plan has to consider, first of all, the event-specific risk. So the emergency equipment must be a part of a documented safety plan that includes the event risk, the human resource, access road and transportation facilities, control central unit, and above all, continuous education. At the same time, the Federazione Medico-Sportiva developed the modules, that means sport emergency management guidelines. Is part of PSSE, was published from Presidente Caldasco and myself in 2012. The organization has been finalized on the basis of a pronto soccorso sportivo. The first goal is to immediate care organization of the specific sport event to cope with any type of emergency, traumatic or not, considering the specific sport risk. Is according to the sport venue safety rules and the National Sport Federation safety rules. Is the figure, sometimes these guidelines should need some sport, it might require a rule change to allow an appropriate or field medicament assessment to occur without affecting the flow of the game or unduly penalizing to injury players' team. The central figure is the match day doctor. Makes it out they must have a checklist of everything we need. We can use a provision of a immediate care leader, emergency team exclusively dedicated to the playing area, procedures exclusively dedicated to the playing area. The match day doctor, educated in cardiorespiratory emergency and catastrophic sport injuries management, with a significant experience in providing medical care in elite sport. 2 paramedics, at 8 for each team, volunteers educated for emergency care. This is my team in Olympic Stadium during Six Nations Championship. This is Professor Nardi, very well known for his competence in trauma. Another significant part of the plane of the organization is the briefing. Upon the team's arrival on the ground, there is a briefing between the match doctor, the team medical staff, referees, team captains. The 4 points will be reviewed. Playing the ground and inside and outside escape routes, emergency team and relevant vehicles location, weather condition, ground condition, emergency signs, operational procedures. The team doctor will be the first to intervene on injured player. Using conventional signs, he could ask the support of the match doctor and paramedics or volunteers. Have a look. In this situation, this player have a trauma, a concussion, and a neck problem. The first supporter is this physiotherapist that made a manual immobilization of the neck. The doctor arriving, he understands what's happened, and they call with this signal the trauma team that is well organized. It is imperative that only official appointed trained medical person are involved in emergency procedures. Another problem is how the team doctor should be dressed. We suggest that instead of a perfect dress, like Armani dress or a Dolce & Gabbana dress that now is fashion, especially in soccer, they must wear a tracksuit, and this is an operational role, so it's much better to wear like that. Full equipped ambulance with mobile resuscitation and trauma units near the closest playing field exit, and mobile resuscitation and trauma easily reachable from the changing room. Very important, the escape routes must be clearly identified and free from any obstacle whatsoever, and all emergency exits must be staffed by authorized steward, because the problem is it could happen in a situation like that. Even if the escape routes are good, this was in Rio de Janeiro, the day after the Congress of last year. I was looking for this match, and 80,000 people attended that match in Rio de Janeiro. They needed to push the ambulance to start again. Elite sport. Another problem is emergency room. Should be easily reachable and close to the playing ground. This is a normal stadium, but for me the best is a Viva Stadium. Emergency room this is very close. It's a walking distance, very close from the ground. Easy reachable space is set like that. Is a fantastic accommodation. But even if not possible, in Italy, soccer stadium are space are ridiculous. So we transform some other space in with all equipment, and it could have easily been done. With also diagnostic is X-ray, echo, and so. So, organizational standards. Of course, at elite competition or international, we maximum standard equipment, match day doctor, immediate care leader, and plus specialist. National competition, standards equipment, match doctor, community grassroots competition, requirement by law equipment, but overall education. Education made through the course. This is an example of a PSSD course. program that is for doctors, is for physiotherapists, for coach, for fitness coach, for officials, and for referees. Now referees are very good friends of emergency team because they understand what's going on and what's happening, and they can help to intervene. This educational problem we did yesterday, yesterday, the first day we did a course, a pilot course here in Portorož with the cardiorespiratory emergency and the traumatic emergency. This is the people who would attend. Was very good. We hope to diffuse this course all over Europe. This is the same course made for an elite soccer team in Italy. This is Inter Milan, Cagliari, and Fiorentina. These are all the technical staff attended to do the practical exercise. Thank you very much for your attention.
Thank you, Dr. Ierstano. All right, thank you. Thank you for your presence. So we can move to the coffee break. Thanks.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
Thanks very much, Dora, and I hope I'm not going to bore people today. I'm going to expand a little bit more on, or quite a lot more, on some of the things that I started to talk about yesterday. Thank you all very much for coming, and thank you for your interest in this project. Dora very kindly said that I was a creator of moving medicine. I'm the leader of moving medicine, but I'm certainly not the creator. The creator has been many people, but I would like to credit Dr. Hamish Reid, who's extremely pivotal in the moving medicine resources, and Dr. Chris Spears, who has been doing a lot with the Active Hospital project, which I'm going to talk about in some detail today, because I think it's one of the most exciting things that we're doing. So, imagine you're in clinic, and somebody walks in, overweight, high blood pressure, pain everywhere, diabetes, feeling angry, wife with him, feeling angry, feeling deserted by the medical profession, feeling like there's nothing more that can be done, and looking to you as the doctors to help him, but also with a fair degree of anger that you haven't done better than you have done so far. What do you feel? You feel maybe I haven't got time for this, this is really difficult, this is a heart-sync consultation. This is a waste of my time. Doing this is a waste of my time. I've already talked to you about doing more exercise, and it hasn't made any difference to you. You might feel a bit hopeless. What do I do now? You might feel frustrated, and I've certainly felt that myself. But what I think we don't understand is that what the vibe we give out to the patient, whether or not we actually say it or not, is that they're lazy. And what happens then is that we positively reinforce the patient's own reasons for not changing by giving out that vibe. And this is the challenge that we have. And I know that every one of you in this room will have felt those emotions at some time during your career, and if you haven't, you will. This is our opportunity, though, to change behaviour. All we need to know is how to do it. And we don't have to spend half an hour on it. We can start that process in just 1 minute. So I'm not going to go into this in detail because, of course, we all know this and we've heard about it a lot over the last couple of days. I don't know what is going on in Kuwait. I suspect they're probably just measuring things a little bit better. Certainly in the United Kingdom, 35% inactive by self-report. We know that the objective data is much higher than that. But we know that healthcare has a unique and important part to play in this conundrum. This is a big conundrum which doesn't just involve healthcare, it's a multi-factorial conundrum, as we all know, but healthcare is a really important part of it. And our government, Sport England, through lottery funding, have recognised that and have given us the money to support this programme, at least in its early stages. We have a unique access to the most inactive parts of our population. This is a physical activity calculator which comes out of a meta-analysis of lots of cohort studies. And what it shows essentially is that people who do 15 minutes of physical activity a week, which is where that line is, 15 minutes a week, stand a huge amount to gain by simply increasing that to 30 minutes a week. And this is a very powerful tool if you use it in a consultation with a patient, because it's something which they can understand. And you can do it as a patient sits there. We all know this is a vicious cycle. You start with low activity, many of us have. You get worse health, you get disease, you become less active, you get more disease, and you are less active again, and so the cycle goes through. This has been recognised by Lord Darcy in his report in 2018. Simply putting more money into the NHS and hoping for the best will not work. We need to shift from diagnose and treat to predict and prevent. And on the basis of this review, our NHS long-term plan is now concentrating very much on prevention and prediction, because prediction is a big part of prevention. And stemming from our long-term plan, we have a green paper which is currently out for consultation, concentrating purely on the prevention agenda, and a big part of that, as we all know, is physical activity. Now, you know, I'm talking about the NHS, but I'm sure all your healthcare systems are the same, and I know from many conversations with many of you over the last couple of days that we all experience exactly the same problem here. Staff have poor knowledge because it's not part of the medical curriculum. Certainly when I trained, nobody told me about physical activity. That training behaviour change counselling is very limited. I've never been trained formally in behavioural change counselling. I've simply tried to find it out for myself. And the systems, our NHS systems, the efficiency in our system and the streamlining our system removes opportunity. So our rapid times for patients to be admitted, discharged, the numbers of patients we have in our clinic, all of the ways that we manufacture that patient journey as they go through hospital, streamline things and limit the opportunities to intervene. So we have a problem. When we talk to healthcare professionals, I alluded to this yesterday, when we talk to healthcare professionals, they have many barriers. The biggest three being time, and I think, as I said yesterday, this is partly time and this is partly lack of priority. They feel they have a lack of knowledge and skills, particularly in physical activity counselling, and they feel they've had a lack of success with changing behaviour. And I'll come back to our patient who walked into our consultation room. We've tried it in the past, but we haven't actually got anywhere. Imagine the conversation that many of you will have had with your patients. I've certainly had it with mine. Don't you think it might help if you could do a little bit more activity? Well, I can't walk because my knees hurt. Well, have you thought about cycling? Yes, but I haven't got a bike. Well, have you thought about going to the gym? Yes, but I can't afford to go to the gym. And so it goes on. And at the end of that consultation, everybody feels like banging their heads against a wall, and the patient leaves the room feeling worse than they did when they arrived. And these are the consultations that we have to challenge. So I'd like you to just all read that and put up your hands if you think that's correct. All of it. If you think this theory is correct, put your hands up. think you're all primed. Well, I'm very glad to see that there aren't any hands up, because I think we have to challenge this view. People don't see, so what we do is we give them insight, and then they'll change. People don't know, we give them knowledge, and then they'll change. People don't care, let's scare them, let's tell them they're going to get ill, they're going to die unless they do something about it. If you make people afraid, they might change. Sorry? Exactly. They don't know how, so we give them skill. This is something which we have to challenge. People generally know that they could be more active, but they're ambivalent to change. They know there's pros to change, and they know there's cons to change, and so they simply put it in the too hard box. People know that it might be good for them, but they also recognise there are benefits to not changing. They're ambivalent, they put it in the too hard box. People do care, of course people care about their health. It's all we've got, our health. We can be as rich as we want. If we haven't got our health, there's no point in any of it. But they're not sure what they care about most at the moment. Everybody knows how to move. We don't have to teach people how to move. Everybody knows how to move. But they don't understand what we mean when we talk about physical activity. Many people think that means going into a lycra and going to the gym. So we are forced into this situation where patients are ambivalent to change, health professionals are ambivalent to change, and essentially that's where we find ourselves at the moment. But we all know that good conversations, and that all of the behavioural change science tells us that good conversations get people to share and reinforce their own positive reasons for change. And what we have to remember here, and if you only take away one thing from today, what I'd like you to take away is that there is only one expert in the consultation room in the patient's life, and that is the patient. Your expertise means nothing unless you understand that. Specifics are important, particularly when we're talking to people about long-term conditions. This is a part of the moving measurement of resources, talking about musculoskeletal pain and osteoporosis in particular. So these are things you'll all have heard every day. I've been told that my scan shows damage, and I don't want to make that worse. So it's a compelling theory, isn't it? If your knees are already damaged, why would you move them more and make them more damaged? I've been diagnosed with osteoporosis and spinal fractures. What if I move more? Am I going to fracture more? Again, these are really understandable concerns. I've already tried this before, and I stopped because I didn't see any benefit. Again, really understandable concerns. So the prescribing movement resources were launched in 2018, and our brief was to develop a unifying brand and a project identity, which we've done. It's called Moving Medicine. To engage a network of professionals to develop the evidence-based resources. Well, to date, we've engaged a network of over 700 different professionals, many of whom have no interest in physical activity. To build a wide-reaching collaboration, which we've done nationally and increasingly internationally. And to design interactive infographics. Now, this is what we moved on from. We started with the idea of just having some infographics on a flat PDF, and we've changed it into a website because we thought that would be more useful, or our users told us it would be more useful. And then to create embeddable coded widgets that anybody can use anywhere in the world on their computer screens, which they can easily open. We've built a huge collaboration now of all of our professional organisations, our Royal College of Physicians, of surgeons, of nurses, latterly of midwives, the Royal College of Paediatrics and Child Health, the psychiatrists, BASM have been hugely supportive, and many of the charitable organisations in the UK. You'll recognise a lot of these people. And this collaboration is really useful, it's really powerful, and it's very important. If you're going to get anything through healthcare nationally, you have to have the professional bodies on board, talking about it, putting it on their website, using it. It's really, really important. Our development pathway, I won't go into this in detail because it's quite boring really, but essentially what we did was if you go look at the blue box in particular, We have reviewed the literature, done narrative literature reviews from 9 different conditions initially, and we've just started doing reviews for paediatric conditions, for 6 different paediatric conditions, and also for pregnancy and postpartum, and a couple of other new modules as well. And we formed, and for each modules, we formed expert panels of clinicians, of all sorts of clinicians, nurses, physiotherapists, occupational therapists, and so on, in each condition. We've taken the literature to condition-specific groups, and everybody has been allowed to comment on the literature and how it applies to clinical practice. And then we went through a sort of exhaustive Delphi process before we published this. This has been developed using what's called a knowledge into action framework. If you look at the bit in the middle, the knowledge creation, this is really what I've been talking about already. You do the literature reviews, and then you adapt it to context, and then you review how it's being used, and you continue on that cycle. And we're probably on the red box at the moment, going around this cycle in the first year. How should we package the information? As I told you earlier, this is something that we'd thought that we would do in flat infographics initially, because that was what the brief was. But then we went through behavioural change framework analysis, what we call a COMBI framework analysis, and realised that that wasn't going to be adequate to address people's capability, motivation and opportunity adequately. So we decided to communicate better through design. Any Meatloaf fans here? And we did quite a big process of asking design companies to apply for this particular piece of work, and it was this slide that won the day in the end. We have a design company who are full of humour, full of life, full of vibrancy and energy, who take our ideas and make them better. And I think this is where health and design are really important together. Because you've got to get people laughing, you've got to get people engaged. There's no point in producing boring resources. It's been done over and over again. So this is what we've come up with. This is the musculoskeletal pain resource. As I said yesterday, we've categorised it into how much time you have available, because as we know, that was a thing that most clinicians told us was the biggest challenge. So you can have a 1-minute conversation during which you just bring up the idea, you share some ideas, and then you ask them to come back to talk about it further if they'd like to. If they don't want to, that's fine. We don't have to influence everybody, but there are some people who do come back, quite a lot of people who come back. And then there's a 5-minute consultation which goes into things in a little bit more depth, and a more minutes consultation which takes you through essentially what should be a 20-minute to 30-minute conversation, which if the patient engages well with, can significantly change outcome. So this is just to give you examples of what's on there. This is part of the more minutes consultation, and this is where the patient gets to explore their concerns about exercise. And these are concerns which our patients came up with when we did the consultation process, and also has been well publicised in the literature. And if you press on any one of these boxes, you'll find an answer to that question which doesn't challenge the patient's concerns, acknowledges their concerns, but helps them move on with it. We build confidence, very important to build confidence and to build motivation, and there's lots of different tools within these resources to do just that, to understand, help patients understand the positive and negative cycles of change. And this is for musculoskeletal pain, but there's also many other resources like for fatigue, for depression, and for all of the other symptoms of chronic disease. And then we have these courses which we're now selling very cheaply, about 150 euros for an 8-week online mentored course, which you can do from anywhere in the world, which essentially helps you build these skills so that they become second nature. As I said yesterday, I've done this course myself. I would highly recommend it. I think it's changed the way I consult, and I know a little bit about this agenda. I'm just going to spend the remainder of my time telling you about active hospitals, because I don't think many of you will have heard very much about this because we haven't yet launched it. This will be launched in the next month or so. We're just going through our final testing phase at the moment. He always makes people smile. Don't know who he is. I think he's American, actually. So we started this pilot in Oxford, which is the place that I work. We've had a huge team in Oxford working on this, probably about 100 people altogether who have been involved in this pilot and feasibility project, which has now been evaluated externally and is going to be rolled out to 2 further hospitals in the UK. Oxford is a very busy place. The hospital, we have 3 different hospitals over 3 different sites. There are over a million contacts annually, and there are 12,000 staff. Legacy of rest, which we've talked about quite extensively. The old Victorian Nightingale wards, where you walk into a ward and there is a bed and you are expected to go and get in it when you get into hospital. My husband, who is only 50, went into his to hospital recently to have a shoulder replacement. He's a GP, he's a doctor himself, very fit man. First thing he did was get in his pyjamas and get into bed. All I'd done is gone downstairs for a cup of coffee. When I got back up there, I found him sitting in bed. I simply couldn't believe my eyes. I said, "What are you doing? Why are you sitting in bed?" He said, "Well, that's what you do when you come to hospital. You get into bed. That's what everybody else is doing." And he's a GP. So we have a problem, we have a really difficult culture to change, and I'm sure this is not just in the UK, I'm sure this is worldwide. We have some hospitals like Stamford Hall, where our military rehabilitation hospitals, where they really have challenged this, where you walk onto a ward and the first thing isn't a bed that you see. You might see a day room, an activity area, some fun to be had, a number of other people sitting around having fun. But this is a young population, it's a little bit more acceptable maybe in that population. But I think when we're designing our hospitals in the future, we need to think about this a little bit more carefully. What we did initially is we went through what we call this COMBI framework, which if anybody of you have used it, it's really important to do. It's a very tedious process, but it is a really important process because it makes you think about things you haven't already thought about. You think about the capability, opportunity and motivation of your staff, and then you think about all the things that are around them that could influence that. And essentially, that moves you to your actions. You think about hospital systems. Where can we influence in our admission and discharge pathways? What are the unique things about each pathway? So how can you use an intervention for example, a paediatric cancer pathway, and how can you use an intervention for complex medical unit pathway of patients who are admitted because they're off their legs, because they've got infections and so on? How do you integrate with each of those pathways? And of course, the approach has got to be entirely different. And I think what we discovered very early on is that you need to engage people from each of those pathways to work out how to do this best. So you don't go into a pathway and essentially try to influence them. You take people who've worked in that pathway for many years, who understand the challenges, and then you use their knowledge and expertise to see what you can do. And that's worked really well for us. The foundations of this, as I said earlier, is all about feasibility, transferability, sustainability and scalability. So how do you scale this up to other hospitals? How do you use the knowledge from the first pilot to scale this up? And one of the ways we've done that is by publishing this online toolkit. So we started off with a little team, the SEM team in the middle there, which was led by 2 consultants, and by 5 trainees, so sport and exercise medicine trainees. We then drew clinical champions, what we call clinical champions, from each of the 5 pathways that we started with, and we designed pathways for these 5. And as you can see, these are multi-morbid pathways. These are not easy pathways. So the amputee pathways for medical amputation, so people who've got to the stage where they've had to have limbs cut off because of medical conditions, not for traumatic conditions. Transplant pathways, so renal transplant particularly. Cardiac pathways, what we've used is the TAVI pathway initially. The TAVI is a aortic valve replacement for people who are too unwell to go through an open procedure. So again, a very multi-morbid population by definition. Medical pathways for complex medical patients who are admitted for complex medical reasons. And the maternity pathway, we used high-risk maternity patients, particularly those with gestational diabetes. We then also engaged a community navigator who went to all of the organisations in our county and worked out a community map which was specific to each of those pathways, because of course there's no point in directing a young pregnant woman to the same pathway as a complex medical admission, perhaps with multimorbidity. Yeah. Well, we asked people to nominate themselves, so we went to the pathway and put in a recruitment process, and so we got people who were interested in that agenda from each pathway. And then, as those pathways became more established, we then withdrew from that pathway and allowed them to continue it while going back into the pathway every 3 months to do ongoing audits, to do quality improvement projects, and basically to keep them on the ball with what they were doing, so we didn't lose touch with the pathway. But as we withdrew from each pathway, we were able to then move into the next. and we've now influenced about 15 pathways, patient pathways, in our hospitals. The design of the pathways is really important, as I said earlier. It's really important to understand the challenges of each pathway. And so we went in and did, with one of our academic colleagues from the university, who's done a lot of work in behavioural change in health. We went in and did a large piece of insight work, asking staff across the hospitals what their challenges are and what they think about all of this. And it was a really interesting, we went right the way through from managers, senior level, executive level, right the way down to the hospital porters, and had focus groups with each of those working areas. And we came up with lots and lots of really useful information from those. This is presented in the toolkit, and so you can use that, you can share that. And you don't necessarily need to do your own piece of insight work, but if you wanted to in your hospital, we've presented on the toolkit an insight framework so that you could do your own insight work to make sure that this is actually applicable to your country and to your area and potentially to your pathway. These are some of the things that we came up with in the insight project, some of the things that people told us, and if you click on any one of those boxes, you'll see sort of ways to address each of those challenges that we've found through our experiences. So this is so, for example, on the pyjama culture, and what our staff told us about that. And then you move on to delivery, and we've published 4 different pathways, sort of really sort of explaining the diverse range of things which are sitting in hospitals. So we've published an inpatient pathway, which is our complex medical unit pathway, an outpatient pathway, which is our maternity pathway for diabetic pregnant ladies, a surgical pathway, and we use the TAVI pathway as a surgical procedure, which is a chronic condition pathway for patients who are in that pathway for a very long time, like the amputee pathway, for example. And then what you need to do, and we've illustrated all of this in the toolkit. This is a very busy slide, so I don't expect you to read it, but essentially what you need to do for each pathway is go through this COM-B, this framework, behavioural change framework, working on capability, opportunity and motivation in each of those pathways. And then you think about how you're going to address them, and this is some of the interventions we've put in place in the complex medical unit. So on admission, the patients have a physical activity calculator done and a 1-minute consultation surrounding that physical activity calculator. So the first thing you do when you clerk somebody into hospital is instead of just asking them about their smoking and their alcohol and where they live, you ask them about their physical activity and raise it on the agenda. You do a physical activity calculator and remind you of the graph that I showed you earlier, which shows patients very clearly how they might be able to move up and down the spectrum of risk by very small changes in what they do. While they're an inpatient on the ward, we have a tool called the I CAN tool, where we make it, or the physiotherapist makes it clear what that patient could do when they're admitted, because of course when patients are admitted, they're often a lot stronger than they are when they're discharged. So I can get myself to the toilet, I can feed myself, I can dress myself, I can walk for 100 metres. And that's really powerful because everybody in the ward sees that, all of the nursing assistants see that, the nurses see that, the porters see that. And so if the porter, for example, is taking a patient down for an x-ray, they might walk them down instead of pushing them in a wheelchair, if they know that they can do that. So very simple things like this which change the culture, raise the profile of physical activity in the hospital. And then we have a number of standing, bed-based and chair-based exercises that people can engage with if they want to. And we have a day room area with videos for those exercises that people can use as well. And then when patients are discharged, they go, if they want to, if they've got to that stage of their journey, there's a community navigator who can talk to them about what's available in their area and what they might be able to get to. Or if they don't want to get anywhere, how they might be able to do things more at home. Just simple things like sit and stand in the commercial breaks on the television. Just sit and stand 2 or 3 times. Those sorts of things that people don't really see as physical activity, but if they do it, it makes a massive difference to their likelihood of falling. These are the sorts of interventions, behavioural change interventions, that we can put in on the complex medical unit. So things like the active conversation, and you can put on, tick on any of these boxes, and then the resources will be downloadable for anyone to use. This will be published on the internet. This is the I Can tool. So it's just basically a poster that sits in the patient's notes, and you can just write on it. This is a laminated poster, so you can change it throughout the patient's stay if things change. We have, obviously, in hospital situations, it's very important to have governance, to change, to audit what you're doing and to improve the quality of what you're doing. And all of NHS pathways run through a governance framework, which is very boring, but it's very important. And it's our way of being able to withdraw from pathways while still monitoring their success. This is just one of the, I'm not going to talk about outcomes in great detail because the first pilot was all about feasibility really. But this is the maternity. So over 10,000 patients were admitted consulted with between those dates. In just an ordinary booking appointment for all pregnant women, not with medical morbidity, but all pregnant women, about 25% of them were inactive. In the diabetic population, if you look to the right graph there, about 37% of them are inactive. And after 2 motivational interviewing consultations throughout their patient journey and a lot of work with what's shown on the in the outpatient department, videos and so on, the self-reported levels have reduced quite substantially just through those little interventions there. You don't have to take people to exercise classes, you just have to raise a profile a little in their own patient's mind. And then in the NHS, of course, you have to plan business cases. We have to have business cases for everything we do. I'm sure it's the same wherever you are. And there's a load of resources there for planning your business case, what sort of things need to go in it, the literature researches, the literature reviews, easy ways of doing a business case, hopefully make your job a little bit easier. This is just a bit about community navigation, which I won't go into any more detail. The training resources we have, a lot of educational resources around. We have lots of slide sets which are downloadable, which anybody can use. We deliver face-to-face presentations across the hospital in grand rounds and in individual pathway educational sort of events. There is in the NHS, and I'm sure because in the European Union there are there's a lot of mandatory training. We have to do training in all sorts of things, infection control, data, you'll have all been through it. I'll have to do about 20 mandatory training modules a year. We're adding physical activity into that as a very short mandatory training module. And then we have our online accredited learning course, which I talked to you about earlier, active conversations for people who want to explore this in more depth. And sometimes what we found in the hospital is that just using one clinical champion who's properly trained, one person who has done the 8-week course, who's really, really well trained in this, they can influence many, many people around them then. So I think it's worth having at least one person who really, really understands this well. And then there's patient-facing resources. The Active Hospital app that patients can download during our hospital stay is something we're working on at the moment, and watch this space. I think it'll be useful for younger patients, particularly paediatric patients, and we're currently working with the paediatric cancer pathway. Lots of materials that you can use. You can download any of these if you want from the internet. Just posters to put around the ward, brighten things up, and all of that. We had a bit of kickback internationally about the word Hoover, because it's, in the UK, Hoover is a vacuum cleaner, but I don't think anybody else knows that. So the international branding is the international question is a little bit more complicated than we originally thought. Yeah, so there's lots of resources there, and widgets that you can download, screensavers you can download, and things that we can provide for free of charge. Other ideas, we've got these going up one of our flights of stairs, and if you open the lift door, there's more information. So there's loads of ways that you can change the environment. Become an ambassador if you'd like to. Particularly young people with energy who want to do stuff, maybe people who don't want to do PhD projects. Become an ambassador, contact us through the Moving Medicine link, either on social media. Contact us and let's talk, because I think the more that we work together, the greater our impact will be. We are gaining traction. This is me. I'm not going to do this now. This is me, and behind me, standing there, it's always good to stand in front of the Minister for Health. That is our Minister for Health, who we did manage to persuade to do exactly that in front of our poster. That's Matt Hancock, who is actually one of the best Ministers for Health that, in my experience in the NHS. I think he's a great advocate. I hope he stays in post. So really, to close, I think we have an opportunity now, certainly in the UK, and I think we have an opportunity worldwide. I think this agenda is gaining traction. I think the conversation is changing. I think people understand this is something that we have to address. We're uniquely trained clinicians. We understand rehabilitation. We understand all of the sort of tenets of deconditioning that we've heard a lot about while we've been here. You have to believe, sometimes I think, really this is just too much hard work, I just want to go and sail around the world and forget all this. You have to believe you can make a difference. Because feelings count more than facts. When we're at this stage in our agenda, people have to feel they can make a difference. And we have to work together. And this comes back to our conversation yesterday about Global Alliance, working together. Trying to use these resources. We're not protectionists over this. Anybody can use it. It's fine. Just use it. If you want to translate it into your language, we can help you do that. We will be keeping it up to date with as the years go through our training program. We have around 40 trainees at any one time in the UK, all of whom need to do their evidence-based medicine, and so we'll update the resources with us. So thank you very much for listening today.
Thank you very much, Natasha. That was an amazing talk. Thank you so much. And great reminder about the Victorian legacy of the rest in the hospital. Yeah, you alarmed me. So there's no doubt where we should invest our energy the next few years, right? It's not about money, it's about energy. Questions to Natasha, please.
I'm sorry, I can't hear what you're saying. How do you start what?
I'm saying the Monty Python approach.
Yeah.
Say brilliant, shouting brilliant, how do you start?
I'm not quite sure I understand what your question
Exactly,
is.
that you don't understand immediately the Monty Python.
Oh, I'm not a Monty Python expert, I'm just using one of their clips.
But the question is not, it's the difficulty. How do you make the first steps?
How do you make the first steps in a project like the Active Hospital project?
Well, it's a general, but if you're looking for people that to join it, you have to say what you do in the next step.
Yeah, I mean, I think the first step is believing that you can make a difference, and then looking around locally and nationally. Use people around you, use expertise like exercises medicine, moving medicine, and don't try and invent the wheel. It depends on your level of engagement, and one of the things on the Active Hospital Toolkit is exactly that question: how do you start? And there's a sort of quiz you can go through to talk about how do you start, depending on where you are at the moment in in your hospital, in your career, in your how much money you've got or not, all of those things, which sort of help to direct you depending on where you are in your journey.
This is a situation when we know we have the knowledge, but we need to break the ceiling in order to change something.
Yeah.
And what I'm saying to you, that the more we talk about it, the more we don't know exactly how to break the ceiling. Because who do you should talk with? Or, you know, in another word, who you should sleep with to do that. The thing is, you talk to the manager of the hospital first to convince him. Do you talk to your national society, or do you talk to the medical association to convince them? Because everybody knows what we know, but yet they're not doing it. So something changed for you. I want to learn from your experience. How do you break the ceiling?
And again, I think it depends on who you are, on your level of influence. If you're a junior physiotherapist, you might just want to influence the people immediately around you. If you're a senior consultant, you might want to go straight to the chief executive and change the messaging that's coming down from on high. There's lots of different ways of starting. A lot of this is presented in the toolkit. But I agree with you, it's not a simple question. And I think it's something that you have to consider when you start. What is my capability here? Realistically, what can I achieve? But make a start, importantly. It's like moving more, isn't it? We don't expect people to go and run a marathon. We expect them to simply move more.
Dora, you know, I don't hold back. I do try and try to succeed. So hopefully we'll do how to make those steps. It's convincing so many people as an obstacle. The obstacles are not the patients.
No, that's right.
The obstacles are administrators, the people standing in front of you.
And our systems.
Rob, I'm sure that Natasha will take more questions in the break. So another question only. Dr. Steinacker, please.
Yeah. Very short, concrete, related to the presentation and to the program. Now you have the program. How to evaluate the program?
Yeah, and it's a good question. As I say, we've got these 2 other hospitals, and we've got a big evaluation program that's going alongside that in the UK, and we'll be producing some data. And I think when we have data, that will be more usable internationally when you go to your hospital executive or to your government level, if there's data that shows impact. And so that's what we're going to be trying to do over the next 2 years.
Thank you very much. And now we need to, we should prove that we listen to Natasha. And what is next? Yeah?
Thank you, Dora.
Thank you very much, Natasha.
So pleased to see at least quite a few of you. I know it's the last session of the conference, but we have really, I know the cliche of last but not least, okay, but it really applies here, you know, that we have some of the best for you now this last session. As you can see, very much looking at the issues of transgender, intersex. And rather than waste more time, just I'd love to introduce our first speaker, which is Joanna Harper, who in our No talk will introduce herself as well. But just from my experience of Joanna, I've learned so much from her. And what really impressed me with Joanna is the fact that she's very much wanting to create, let's say, some outputs and some impact in the field, which is evidence-based. And she's recently joined Loughborough University also as a doctorate student, again epitomizing her wish to make the recommendations, the guidelines, evidence-based. So without further ado, Joanna, enlighten us, please.
Thanks for the kind word, Jonas. So as Jonas said, I just last month started at Loughborough University. I'm from Canada originally, and how do I advance the slides here? There we are. Okay. I have a book coming out in a couple months. My publisher wants me to push it, so there's the slide. If we talk about transgender women in women's sports, the first thing that absolutely has to be said is that even after hormone therapy, transgender women will still have advantages over cisgender or typical women. That transgender women will be taller, larger, and stronger than cisgender women on average. Transgender women also benefit from muscle memory, more dense bones, a more efficient cue and carry angle. But transgender women also have disadvantages too. The most significant disadvantage that transgender women have is that their larger frames are now being powered by reduced muscle mass and reduced aerobic capacity. And so this can lead to issues of recovery, of endurance, and quickness as well. And so transgender women also have disadvantages. And of course there are some sports where it's better to be smaller. And obviously transgender women will be disadvantaged in sports like gymnastics. But we allow advantages in sports. So the question isn't, do transgender women have advantages? The most important question is, can transgender women and cisgender women compete in sport in a meaningful fashion in which both categories have a reasonable chance to win? For instance, we allow left-handed fencers to compete against right-handed fencers, even though left-handed fencers have multiple advantages. We don't allow heavyweight boxers into the ring with lightweight boxers. So how do the advantages that transgender women have play out? Well, let's look at some science. A couple studies on muscle mass, one from Guren in 2004, and a study that just came out a couple weeks ago from Stockholm showed that there was a reduction in muscle mass, 1 year of hormone therapy. Guren got 9%, the Stockholm people got 5%. Which of these numbers? Well, both of these studies were in non-athletic populations, and these are the only two studies. They're both fairly small studies. Hopefully we will get more data. The Swedish people also did a measurement of strength, and they lower body strength. They did 3 different measurements of lower body strength, and they found that the transgender women in their study had no loss of strength. But they also found that the transgender men in their study, and there were approximately 6 subjects in each cohort, gained 18% strength in 1 year. And I find both of those numbers a little unbelievable, and the authors themselves admitted that if you take a non-athletic population, you give them a strength test, allow them to repeat that test over a year, obviously they're going to get better at that strength test. And so the actual loss of strength may not be accurately measured by this particular test, especially in athletes. So finding transgender athletes to test has been very difficult, and I was the first person to do it. My study in 2015 got race times from 8 transgender women. All of them were at least 10% slower after transition, and I used a method called age grading, which is the standard method used by World Masters Athletics to measure athletes of both sexes and all ages in athletic competition. Using this methodology, the trans women were equally competitive after transition and before transition. But this is not a strength sport. So what can we say about strength sports in trans women? Well, I've continued to gather retrospective data. This is a transgender rower that I gathered data from. Rowers are in a boat with 7 others, so how do you get their data? Well, you actually put them on a rowing machine, you have them row for 2 kilometers, and you measure their times. And these were Ryan's data. At 18, she rowed 7:01 for 2 kilometers prior to starting transition, and then 2 years later, when she resumed rowing, 7:25 to 7:11 to 7:05. If you assume that her progression from 20 to 22 is typical of rowers, and her coach said that it is, and you assume that sort of progression from her meal time, then she's roughly 10 to 12% slower. We can also look at athletes in sports where there's not this necessarily direct measure. It's not quite as efficient, but it can still be illuminating. Hannah Mounsey is an Australian handball player. She was a member of the men's national team. She stands 1.88 meters tall, weighs 100 kilograms, and she's 29 years old. If ever there was a trans woman who would dominate her sport, it is Hannah. And she played for the first time in December of 18 internationally for the Australian women's team. And pictures like this flooded the internet, with Hannah showed being much bigger than her opponents. And how could this possibly be fair? But if you look a little closer, she was the 3rd leading scorer for the Australian team. The Australian team placed 5th out of 10 teams in the Asian Championships. Now, it should be said that Hannah was not the 3rd leading scorer for the men's Australian team, and she is more successful in women's handball than she was in men's handball. And these are because of her size and strength advantages. That's absolutely true. But she doesn't dominate the sport. And why could it be that someone who is that successful, that big, that strong, that young, doesn't dominate women's sports? A lesson can be learned from Paralympics. Just because bodies look different doesn't mean that you can't have meaningful competition. In the swimming competitions, they put many different types of bodies into the pool together. And if you look at the athletes on the right who are medal winners at a Paralympic swimming competition, you can easily see that on dry land, these 3 athletes might not be considered equitable, meaningful competitors, but in the pool, they did have meaningful competition. So, Tokyo Olympics are coming up. There has never been an openly transgender Olympian. It will probably happen next year. Hannah, who I just mentioned, has a shot. The Australian team is ranked roughly 20th in the world, and there are 12 teams that make the Olympics. So it's an outside shot that she will make it. Another woman with an outside shot is Brazilian volleyball player Tiffany Abreu. She is good enough to make the Brazilian volleyball team, but is unlikely to be selected. The most likely athlete, and I'll talk a little bit more about her, is Laurel Hubbard, a New Zealand weightlifter. But it's very unlikely that there will be many more or any more than those 3 athletes. If we look at statistics, in Rio Olympics there were 4,700 women who won 460 medals. Transgender people make up roughly somewhere between 0.5% and 1% of humanity, and so roughly 1 in 150 persons is transgender. So if you look at the numbers from Rio, extrapolate them to Tokyo, there should be 30 transgender women in Tokyo winning 3 medals. So the idea that maybe there might be 2 or 3 transgender women in Tokyo shouldn't get people all that excited. In fact, transgender women will still be hugely underrepresented in the Tokyo Games, and just as, of course, they've been in every Olympic Games since the IOC first put in rules to allow transgender athletes to compete in 2004. Now, talking a little bit more about Laurel, and I apologize, I don't have slides on her, but if you follow this subject at all, she was much in the news over the summer. She won a competition, the Pacific Games weightlifting competition, where she lifted 268 kilograms, besting other lifters from Oceania and from the Pacific Islands. And this made news all over the world. She lifted 268 kilograms in that competition. Just last week, she finished 6th in the World Championship. She lifted 285 kilograms. But because she didn't win that competition, it didn't make the news. Now, 285 kilograms is a lot of weight. But the winner in that competition lifted 330 kilograms. 4th place lifted 303 kilograms. So while Laurel is very successful, the most successful transgender female athlete ever, she's not likely to win an Olympic medal. And so, here we have the most successful in an entirely strength sport, and she still doesn't dominate the sport. So, if we look to the future, what needs to be done is more research. And I've shown you some retrospective data that I have gathered, but if we're looking to move forward, what we want to do is we want to find transgender athletes. We want to get them into the lab before they start hormone therapy. We want to do baseline tests on them and then test them as they progress through their transition. I'm currently involved with 3 such case studies, and it's very early, but we do have some marked differences. This is a triathlete, and we're looking at her peak VO2 here. It's kind of interesting that she dropped almost 15% of her peak VO2 as she transitioned, but she rebounded a little, and now she's only down about 10% of her peak VO2. Part of that, though, is the measurement here. This is not divided by body mass, and like many transgender women, she has put on a little weight since her transition, and so if we did relative peak as opposed to absolute peak, these numbers might look a little less jagged. So these particular athletes that I found through social media. I too am a transgender athlete, and so I have connections with these athletes. But moving forward, we have to do better than this. What we need to do is we need to do somewhat larger scales. And by larger scales, there's still going to be relatively small studies because finding transgender athletes remains difficult. But what we need to do is we need to pair exercise physiologists at universities around the world with gender clinics where transgender people go to, for assistance with their transition. And that way the exercise physiologists can work with the endocrinologists at these clinics. They can access the athletes prior to transition, get them into the lab, study them as they go through, and work cooperatively with the endocrinologists to make sure that the hormone levels of the athletes remain appropriate. As of a year ago, there were no universities doing such studies. There are now 5 or 6 in the world that are initiating such studies or are very interested in initiating. And one of those universities is Loughborough University in England, and they convinced me to move over there, and I just did so last month. And I'm very anxious and hopeful to see what we will produce over the next few years, but gathering data is a time-consuming process. Let's switch focus briefly to intersex athletes. Intersex is a fairly broad term encompassing a lot of different differences of sexual development, or DSDs. But the particular DSDs that are of most interest to sport are XY DSDs, where human beings are born with a Y chromosome, and the testes that come with a Y chromosome. These individuals have their testes internally, and when they're born, their external genitalia appears female-like, so they are assigned female at birth. And in some, but not all of these XY DSDs, these athletes will experience a male-type puberty and will gain virtually full male athletic advantage. So it becomes a very difficult situation. What do you do with somebody who was assigned female at birth, who is raised female, but goes through male puberty? The IAAF and the IOC have been dealing with this since the 1930s, and there still is not a uniform consensus on how to deal with this. The IAAF in 2018 came up with their DSD policy, where they restricted athletes in the 400 to the 1500 meters to testosterone limits of 5 nanomoles per liter or less. These regulations were challenged in court, the Court of Arbitration by Sport, by Caster Semenya. She lost that challenge in May of this year. She has appealed to the Swiss Federal Court, but it does not appear that challenge will be successful. So one of the questions people ask all the time is, why did the IAAF choose the events from 400 to 1500 meters? Because those are where the athletes are. And there's not necessarily a logical explanation of why XY-DSD athletes are hugely successful in the events from 400 to 1500 meters, but they are. Jonas and I, or H&P as I list here, published a paper last year where we looked at 25 years of podium placements by presumably XY-DSD athletes. And we found a 1,700-fold overrepresentation in the events from 400 to 1,500 meters of XY-DSD athletes. 1,700-fold. And so this is not just about Caster Semenya. This has been going on for many years. And even this year, there were 4 cases of XY-DSD athletes that were new to me. They, of course, have had these XY-DSDs for a while, and all 4 of them compete in the restricted events. So, in conclusion, there is no one thing that you can do that is universally fair to billions of potential female athletes who deserve to have a category in which they can enjoy meaningful sport, and is also fair to tens of millions of athletes who are either intersex or transgender, who are very marginalized groups, and all they ask is to enjoy the same rights as everyone else to compete in sport. There is nothing that you can do that is ultimately fair to both of those groups. I think that where we stand right now, the testosterone-based rules that the IAAF introduced in 2018, the IOC introduced in 2016, are the best things that we have to go by. Perhaps in future, and especially with transgender athletes, once we get more data, it might make sense to be somewhat more restrictive of transgender athletes, or perhaps assign them some sort of handicap or something like that. There are a number of things that could possibly be done to try to level the playing field, but we need more data. And so hopefully there will be more universities, more exercise physiologists around the world who will be interested in starting programs like this to study transgender athletes. I would be happy to give advice to anyone, but the bottom line is the controversies around transgender and intersex athletes are not going to go away anytime soon. Thank you.
Thank you very much, Joanna. You certainly added a focus to an unclear for most of us world, and thank you very much for this. Certainly, being in the IOC Commission, it will help as an advisor, it will help to this topic, and good luck with your PhD. That's to change a continent, it's a dedication. So good luck with this, and hopefully 2020 will be a successful year, successful Olympics for this topic. Thank you very much. Questions now or at the end?
Maybe at the end, Jonas? Yeah.
Yeah? Okay.
Yeah.
Now, the last speaker of today's hot topic session and the conference is Professor Psiladis from the University of Brighton. Yannis is IOC advisor, IOC Medical Commission, and many more, you know, so I don't have to talk about him. But Yannis met Joanna a few years ago, and now he is the main focus of his research at the moment is that the transgender athletes, and a lot of his energy is added to this project. So, Yannis, please.
Thank you, Dora, and I really wish to thank Dora for putting this session into the program. I think it's so vitally important that we actually correct a lot of the misinformation that's out there. And who better than Joanna to actually enlighten us? Joanna may be a doctoral student, but I'm actually one of her students as well. Almost everything I know I've learned from Joanna, and she certainly enthused me to get involved in this very, very exciting area. Due to time, and I want there to be time for discussion, there's quite a lot of overlap with what Joanna has said. I think our conclusion is almost identical, so if I don't get to the end, it's okay. I really want us to have time for discussion. But also I will focus, because of time, more on the intersex and the transgender, and on likely solutions that Joanna alluded to. And those solutions that I believe are relevant for intersex apply equally well to transgender. So I will focus very much on intersex, just due to time. And I'll go over some of the background quite quickly, because I want to get to the solutions, and Joanna's already covered some of the introduction better than I can. And I really want to start off with this slide, because this is the slide this is what causes the problem. This notion that sex is binary. And as we heard from Joanna, it's not always that way. And that is the issue. Also, our competitions in, say, the Olympic Games tend to be male competitions and female competitions, binary again. But the reality is somewhat very different to that. And therefore, how do we accommodate the fact that there are athletes, like what Joanna mentioned, the intersex athletes, how do they fit into this non-binary categorization? And I think by the end of this presentation, if you don't already have alluded to what the solution should be, again, under Joanna's guidance, we've come up with a solution that I think works. And let's try and get there by the end of this session. Just in terms of prevalence, you can see highlighted in this paper by Stefan Berman in the yellow, the prevalence of hypergenetic 46 XY-DSD in our athletic population is approximately 7 per 1,000, which is 140 times higher than expected in the general population. So again, this is a reality. And Joanna went over the kind of history of the different rules and different activities of the IWF and the IOC. I'll very briefly go over those as well, just again to point the picture or to summarize the situation. So this is quite an important time here, April 2011. IWF introduced eligibility rules for females with hyperandrogenism. And let's look at possible impact of those rules. Some of those that this rule implicated, high-profile cases, Duty Chand and also Casa Semenya, but let's have a look at what happened in London 2012. Okay, so keep this result in mind as we move forward, but just give me the opportunity as well just to remind us a little bit about the winner there, Savinova, who has got quite a pedigree in terms of successes, as you can see here. But listen to this. So that race in 2000 quite an interesting point to make. And now we know the situation with Russia, which I won't dwell, but just to make a point that doping is not only a Russian problem, just to make sure that we're all clear about that. Next kind of part of the story goes to October 2014 with this athlete here from India, Duty Chand, who actually, as you can see here, appeals against the ban for failing a gender test. Basically what they mean is that due to her high levels of testosterone, she takes a case to the Court of Arbitration for Sport and wins the case. You can see why here. There is presently insufficient evidence about the degree of the advantage that androgen-sensitive hypergenic females enjoy over non-hypergenic females. And then this rule gets suspended. Let's look at the impact of that rule. Have a look at what her fellow athletes thought of that race. Look at what Savinova said. Just look at her. The irony of saying this when she was currently doping with EPO. But anyway, that's another story for another day. We're going down to 2018. The IWF introduces new eligibility rules. And then we hear some few weeks later, here on June the 19th, Casa Semenya takes her case to CAS. cut a long story short, 1st of May, she loses the case. Then 3rd of June, she's allowed to run again. And then we go a little bit later here, 30th of July, she's banned from running again. What a mess. This is a mess. And as we heard from Joanna, we need science, we need an evidence-based approach to deal with this mess, and the politicians should somewhat stay out of this. So this is the important part of my presentation, which is, well, what can we do about this? Well, the way I think of this, and as I feel great honor to be part of the group that's looking at this as part of the IOC Medical and Scientific Commission. And this is what I'll share with you now is not the IOC's view, it's my view and my way of thinking about this. And the first thing I think about is the law. We have to take into account the law, and the law has changed in many countries, like in this case Germany. The next thing we have to take into account is the Olympic Charter. The Olympic Charter is very, very clear. This is the 2019. And you can see here very clearly there should be no discrimination in terms of gender, in terms of all these other aspects that you can see here, and you can read in your own race, color, sex, etc., etc. So clearly we've got to take that into account. And then, as I said to you, I got excited about this, working with Joanna, in discussions with Joanna, and also as a chair of the Science Commission of FIMS, we really want to try and deal with the situation. And in our FIMS journal, we wrote this first paper back in 2016, The Biology of Inclusion of Transgender Intersex Athletes, where we focus very much on this notion of muscle memory, which is really one of the key issues. And I don't have time to go through this, but very briefly, untrained muscle, trained muscle, you increase the minuclear number as a result of this hypertrophy. When there's detraining, the number of minuclear number remain the same. When an individual transitions as well from a male to a female, what happens to the minuclear number? And to cut a long story short, this is exactly the kind of studies we're doing now, where we're monitoring individuals who are transitioning and doing the muscle biopsies before and after the transition. I'll come to that towards the end. But this is the issue that we're trying to deal with. At the same time, we have to think about the fact that typically in females, these are the levels of testosterone. In males, this tends to be the levels of testosterone post-puberty. And we've got to keep this into account when thinking of the solution. Joanna's already mentioned a little bit of this in terms of this paper by Stefan Bermon, which refers to where in certain events where if you look at the higher tertiles for testosterone, you can see at 800 meters and 400 meters here, hurdles and 400 meters without hurdles, in the hammer and in the pole vault, the athletes on the higher tertiles had better performances. And so the key results here, you can see here, women with the highest free testosterone tertiles performed significantly better in 400 meters and those events that I mentioned. You can see the percentage difference here. And so there's clearly an advantage there, but I believe it's more than only in those events. But this is where one can talk about the statistical analysis employed in this particular paper. We can talk about that later just because of time. In another paper by Stefan Bermon, he also shows what happens in 3 athletes with DSD over a period of hormonal treatment. This is the baseline before treatment. This is actually 1 year after, this is 2 years, and you can see what happens to performance, a drop in performance from 100% as you would expect. So clearly there's the impact of hormonal treatment. So we want to understand, well, okay, take into account what I've just mentioned, the prevalence of this, the levels of testosterone that is typically male and female, the law, the charter, what can we do? And together with Joanna, we published this paper together with some other colleagues, presenting a solution here, which is very much along the lines of what Joanna mentioned, which is to use a biomarker, in this case testosterone levels, as that biomarker, which is not perfect, but at the moment it seems to be the best available marker that can be used. And Joanna coined this term, the athletic gender. So yes, we have male and female categories, but you race in each one of those depending on your athletic gender, and I'll come back to that. So we want to actually test this notion of athletic gender using these kind of biomarkers. And we went to 3 events to actually test this out with our sports physician audience and others in the audience. There was a spring conference at Basel, the public lecture at University of Brighton, and also the 12th Congress of Sports Medicine in Greece. We gave a simple questionnaire which basically asked our audience to evaluate the notion of athletic gender Do you agree or disagree? And if you disagree, why do you disagree? And part of this roadmap, as I mentioned to you, I had the privilege to do this roadmap with Joanna. She presented, as I mentioned to you, at the meeting at BASM. Just go this quickly, and here's us presenting. And again, I thank you, Joanna, for coming to this event. It was really very successful. The event in Greece as well, typical hospitality by the Greeks, excellent wine, but we won't worry about that. But you want to know the data. So what did the audience think, okay, of this notion of the athletic gender and using these biomarkers? We'll go straight to the data up here. Over 70% agreed. Those who disagreed, the main reason was, as you can see in 47, was biological difference and the issue of muscle memory. And those of you know of my work, I'm also particularly interested in improving the current anti-doping detection process, and this is also relevant in terms of doping. Why? Because the issue of muscle memory is also relevant, because if an athlete is taking testosterone levels, testosterone as a drug, that will have impact on my nuclear number, for example, and then if they stop taking the drug, maybe there's still the impact of the drug long term. And just to illustrate that point very quickly, and I'm sorry I'm going this very, very fast. Here, for example, we see in the World Championships in Beijing 2015, there were a large number of athletes who had previously been suspended, but now able to compete again. And this was done, this beautiful analysis was done by the New York Times, saying here that there were at least 120 athletes competing in the Rio Games who had previously been banned from competition. So this muscle memory issue is really of relevance as well, not only in transgender and intersex, but also in terms of doping. And here you can see in this table the athletes, when they won medals, when they were banned, and when they came back and won some more medals. In this case, in Rio, another 31 athletes won medals who had been previously banned. Could they actually have a benefit from the previous doping regime that they used? That's something we're interested in. And we can hear Usain Bolt what he thinks. So he's talking about life bans, because if we can demonstrate that there are permanent effects in a court of law, then this could probably stand up in a court of law. And the animal studies show this quite nicely. Here you have a sham treatment in these mice versus a steroid pellet of testosterone. The cross-sectional area increases as a result of the intervention here. After 11 weeks break, which is equivalent of 1/3 of the animal's lifetime, you can see what happens when they come back to train. They start at the same point, but the ones that have taken the previous testosterone increase far more dramatically. And its explanation, I'm sorry I'm going off this very quickly, is due to my nuclear number, which seemed to be fairly permanent. And the question is, does this happen in humans? We were funded by WIDA to look at this, a study that we received $250,000 to conduct. And together with the IOC, we're doing 3 different studies. We're doing this particular one looking at power lifters, biopsying them at different stages of their drug use. The animal work that is a replication of the previous study that I mentioned, and also transitioning 20 male to female and 20 female to male. And very briefly, where are we in terms of this? In terms of our wider study, these are the various groups that we are using. So a control group, trained power lifters who have a history of training but not free from performance drugs, others who have actually been exposed to drugs, and another group that have previously self-confessed but currently free. And we are conducting muscle biopsies. We look at my nuclear number. You can see what we're doing here, and results are expected at the end of this year, so I look forward to sharing that with you later on in the year. In terms of our animal work, we are training these mice, as you can see here. You can't see it, won't run. Okay, but these mice are being trained with testosterone, and we're looking at what effects it has when you withdraw testosterone. Again, we hope to share these results with you soon. This is based at the Murdoch Research Institute in Melbourne, Australia. In terms of our transition study, transgender study, it took us a long time to get ethical approval to do this, because these are patients that are also going through the NHS. In this BASM magazine, we published our idea of what we're trying to do together with our friends at Tavistock Clinic in London. And now we have ethical approval, and our first volunteers are actually being recruited. So to conclude, and I apologize for going over this far too quickly, but I wanted to make sure we had time for questions. This is a summary that I'd like to share with you. So the right to compete in sport should be secured without any kind of discrimination. I think everyone should can equally agree to this, I'm sure. Well, I'd hope anyway. More studies involving new biomarkers should be developed. And I think this is absolutely key, and that's exactly what we're doing. And I look forward to sharing and also looking forward to Joanna's results soon. Currently, hormonal control, although imperfect, is the best way to ensure as fair as possible inclusion of intersex transgender athletes into elite sport. I think there's no debate about that. And when human rights lawyers say that the bottom line should be whatever someone self-identifies and that is it, I think it's just not plausible. And therefore, I think politicians and political opinions must not dominate. We must make sure that is not the case. We have to make sure that science is at the top of the hierarchy in decision making. This whole view we submitted recently to BJSM with key colleagues from around the world. Unfortunately, it was rejected, but we'll try again somewhere else. And I'd just like to end off with a small little video clip of why I think this kind of solution does work. I feel much happier watching this race and this result than in the previous races. And with that, I'll stop and I'll thank you very much. And I look forward to some questions. Have we convinced you?
Thank you very much, Yanis. I can't wait to, to have the results of your new studies. This is a big excitement. And I hope in 2 years' time, the next EFSMA conference, we will be miles away from where we are today.
So, have we convinced you? Questions?
Comments?
Don't be shy. A few years ago, we didn't know anything about the topic, and now we're more confident, but not that confident, so don't be shy. Dr. Steinecker, please.
There's a big discussion. I thank you for this excellent presentations. Both of you have done good presentations, and it's a challenging issue. The major discussion is human rights of the transgender athlete to compete versus the right of the females to have a female competition. And that's a challenge. Could you comment on this?
Yeah, I absolutely think that transgender and intersex athletes have a right to compete, but when we subdivide sports into different categories, we don't necessarily ensure that somebody has the right to compete in the category in which they would most like to. I compete in masters athletics, and if I competed in older age divisions, I'd kick ass. But I don't. I get to compete based on when I was born. If we compete in sports where we divide by weight, again, you're going to do better in a lighter weight category, and you might like to compete there, but we put athletes on a scale. And so we should use a biological method to separate male and female athletes.
What I'd like to add to that is what I showed you in my first slide there, this notion of, and in your wording of the question, Jürgen, you talked about in the female category. I think this is what we need to readdress, in the sense that, it should be the two categories, okay, and then you have the athletic gender that you can compete in this category because of your athletic gender, which we can term female, is not an issue, but it's an athletic gender rather than a biological sex. And I think, because at the end of the day, as I mentioned to you, in Olympic sport, we have this binary categorization, but humans aren't binary, and that's the issue. So it's just a changing of nomenclature and wording of it. And then I think it resolves the issue. Then it's not an issue of human rights of females to compete against transgender females, whatever the case is. It's just basically, it sorts it out. So I think it's quite clear. That's why I was really quite excited when Joanna's idea proposed this notion of the athletic gender. For me, it makes so much sense. We don't care how people want to live in their lives outside sport. So during the day, you could live your life as a male as you wish. But if you want to compete, you've got to compete in the category that you want to compete in. But you need to have the right, let's say, the requirements for that category.
Yes, please. Dr. Sellon from the UK.
does it cross all disciplines, or could you see somebody having an athletic gender for athletics, but a different athletic gender for weightlifting, for example?
Possibly.
Then it gets complicated.
Yeah, I would, again, I would think maybe in weightlifting that we would still allow a person to compete in weightlifting, and particularly a trans woman, but perhaps handicap them in some way. I don't know. It's an evolving issue. But in theory, yes, you might have a different athletic gender in different sports.
Okay, I must admit, in a sense, I said to you earlier on that I always agree with Joanna. This time I disagree. I disagree on two notions there, and it's very much in line with currently what has been worked on in terms of guidelines, recommendations. Is there should be a period of time in which you declare this is what I'm going to be, and you have to be monitored to make sure that you fulfill that category. At the moment, the idea is to be at least 12 months. I think our data will tell us if it should be longer than 12 months. 12 months may not be long enough. And there is a debate whether if you declare once that you want to go into this, you want to compete as a male or as a female, whether you have the right to change 4 years later. There's a debate about that too. And I don't think you should be jumping into this sport and that sport. I think then it gets really quite problematic. It's nice that we disagree sometimes.
Dr. Wernick, the medical director from WADA.
Yeah, first of all, I think that was a very interesting point, and I think the handicap's a great idea. It's the problem is in the practice. How are you going to do it? There is one sport already, it's equestrian, where there is no differentiation between gender. They all compete together. But the comment I just want to make is just to add to the kind of the confusion, difficulty. Even if we're talking about, as you say, that this idea of having a straight hormonal level would kind of level the playing field to some degree, and the level that we're all talking about now is 5 nanomoles per liter. So what you have is you'll have transgender going to that number. You'll have the DSD athletes, but then if you have an athlete who is not a chemical castration but an orchiectomy, then in a sense they have absolutely no testosterone because they have no gonads of any kind. So some of those athletes have actually requested to be allowed to take a very, very small dose of testosterone to get them back to, again, the controversial notion of what is a woman's level of a very low testosterone. So just add that to the mix of your business.
Yeah, Alan and I have talked about this case before, and personally, and this may be oversharing, but I am a trans athlete who has had gonadectomy, and I still feel that I can compete with other women. Not all trans athletes think the same way, and it is certainly an issue that needs to be discussed.
I'd just like to add as well, and that's the reason why I showed that paper we submitted, because we try and deal with those kind of issues, because not only that to actually add to the mix, it's not only levels of testosterone, we should be looking at free testosterone, the bioavailability of testosterone, that we should also be looking at basically the receptors as well, in the sense, so trying to incorporate all these different components in the solution, which I think the athletic gender does deal with that. I'm totally against the notion of a handicap, and also the notion of giving individuals the chance to actually take testosterone to get to that level. I think that shouldn't be the case, and that's what we propose currently.
WADA, in actual facts, tries to stay away from the eligibility issue. We're no fools. We realize that, so we hand that to the IOC and international federations. However, if an athlete would want to take testosterone, a transgender woman, that's where we would have to get involved, and for the moment the answer would be no.
And just very briefly, I know you're going to want to ask a question, but just very briefly, Alan, I disagree with that. I think WADA should be involved in this, because the complexity and making this solution, even that we are proposing, work requires the cooperation with you, because unless you cooperate, it becomes a lovely idea, but it fails implementation. And I think that was also very clear from the CAS decision with Casa Semenya, was very much how do you actually implement this? And I think the only way we can implement is working closely with WADA. And so if you're holding back and saying it's got nothing to do with us, will mean this won't work.
Just to clarify, Jonas, I don't think that Alan is suggesting that. I just think he's suggesting that IOC and IAAF make policy.
Oh, okay.
And yes.
Okay.
Yeah.
Sorry. Okay.
Yeah. And WADA definitely wants to be involved.
Oh, absolutely. Okay, so wipe out that last comment of mine. Irrelevant. Thank you.
Very short comment. I think it's very important that this bodies are involved. As I am chairing and as Sports Commissioner of Life, we need guidelines and I think that under the guidelines and we work with that. We know also that estrogen has anabolic effects, but not as much as testosterone. But I think we have to work on this issue. There will be next advancement coming, and if you have, let's say, a Mali, let's say, if you have a male athlete, Mali, or you have to meet, you will have the right to take it.
Oh, yes. Okay. Yeah, okay. Thank you.
And I think that this IOC is making a way of this responsibility, and I don't think that others take the way they like to respect the
So I knew that this will be an interesting topic. Is anyone, any comments? No? Well, both of you working close with IOC as an advisor, as a medical commission member. Hopefully, in 2 years' time, we will be in a different level.
If the politicians allow us, yes.
Thank you very much for your attention. Thank you both for this very interesting and hot topic. And we hope that we inspired you today to be more involved in these new topics in sports and exercise medicine. Get involved, help this world. Thanks everyone for being here, and I hope you enjoyed the session, and we have to start with the closing ceremony. Thank you very much both.
Thank you. Thanks so much. Thank you.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOL Evo poskrbite za motor vašega vozila.
Who will be the ones who will give the awards? Members of EFSMA Scientific and Education Commission will deliver the Young Innovation Award for the best poster to action in young athletes. Congratulations. Congratulations, yeah. Young Investigation Award for the best poster goes also to Alina Maria Smaranda for the science. Young Investigation Award also goes for the best oral presentation, and the first winner is before. Young Investigation Award for the best oral presentation goes to Lev Putilin for blood pressure, autonomic nervous system. Thank you, members of EFSMA Scientific and Education Commission, Dr. Sandra Rosenstocker and Professor Xavier Bigard, to present the next host of EFSMA Congress in 2021 in Budapest.
To show you Budapest and why should you choose and why is it maybe we so it was implemented in the presentation. Oh, it doesn't.
Do you have it somewhere else?
I have it, yeah, I have it in the pen drive.
Yes.
Fantastic, thank you very much.
Put your record on and listen, inspired by rich tradition, yet daring and bold. A cultural feast.
So the proposed date for the conference is, please save it, is from 28 to 30 of October 2021. The venue will be the Budapest Congress Center, and Hungarian Society for Sports Medicine will host the conference. Our society celebrated 50th anniversary in 2016, and we are very proud that we are one of the founding societies of EFSMA. Our society organized several national and international conferences. For example, the latest conferences we organized was the 27th FIMS World Congress of Sports Medicine in 2002. There were, we also represented our society in other international conferences, and I'm sure that some of you recognize themselves in these pictures. We have 3 patrons: Association of Hungarian Medical Societies, Hungarian Olympic Committee, and Minister of State for Sports from the Ministry of Human Capacities. Sports sector disposes of high priority. Budapest is this year the European capital of sports, and hosted more than 120 international sports events in 2019, including World Table Tennis Championships, World Fencing Championships, Canoe Sprint World Championships, and latest the Pentathlon World Championship. This, the Congress Hotel, if some of you remember, is the same venue that it was in 2002. The advantage, it has also an advantage that the hotel rooms and the hotel are together with the Congress Center. You can see some picture about the hotel and about the facilities and historical centers nearby to the hotel. We proposed a scientific program. We will discuss it with EFSA, of course, but the main topic should be multidisciplinary approach, innovation for health and performance, because it's a good opportunity to have all of professionals to participate, and we are planning also symposia with the issue towards active Europe, with the participation of WHO and EU, and I think it should be also an interesting topic to follow up Tokyo 2020. social program, as you wish, so I don't go in details. Budapest has an advantage that easy access from all over Europe, even good overseas connection, no need for visa, and so on. And Budapest has a vibrant cultural life with different kind of music, a fantastic gastronomy. So the goulash period is over. We have several even 2-star Michelin restaurants. And so really and our wineries are really very beautiful. And after presentation you have an opportunity after the section to try several spa facilities and spa treatment. And we have several historical attractions, 8 UNESCO World Heritage Sites, and Lake Balaton and Danube Bend, and of course there's wine rides. And 1 week before, based on the voting for the European best destination, Budapest won the prize, so the European best destination in 2019. And thank you, and I'm delighted to invite all of you to participate in Budapest. Thank you very much. Thank you, Petra, for the opportunity.
Thank you, Professor Eva Martos. And now the final act of this Congress. Please welcome for the last time and for the closing speech, President of...
Dear participants, you find the program organizing and the scientific committees prepared together with the EFSMA Executive Committee useful and up to date. The gathering with 450 colleagues from 42 countries was for you for sure a big help in your further personal development in the field of sports medicine. I am delighted that in 3 days of the Congress, 70 lecturers from 25 countries deliver 75 lectures, 6 workshops and 3 courses. For all support and help organizing the Congress, I thank again many scientific and education organizations as Imagine Federation, Latvian Sports Medicine Association, Sports Medicine Association of Greece, Hungarian Sports Medicine Association Primorska, and Alma Mater Europaea. The Congress would not happen without our sponsors, Porsche Cooper. Thank again also to all exhibitors, to the Grand Hotel Bernardin, which hosted us for 3 days in a very professional way, and the PCO, and to my family. I also thank to the distinguished lecturers. Special thank also goes to the municipality of Piran and Slovenia for their directions for the development of sports medicine. I believe we succeeded. With your help, we all together will be at the forefront of our professional career and after its completion, and to promote a wide range of sports activities to the general public. For country, for sure you found or you will find a time to take a glance also to our beautiful countryside. During the Congress. As said at the beginning of the Congress, it is only through joint efforts that the sports medicine profession can I wish you to have a safe trip back home and see you in 2 years at the 12th EFSMA Congress of Sports Medicine in Budapest.
Naj gre za dolgo ali kratko pot. Zdaj lahko poskrbim za svojo družino, ker moje gorivo poskrbi za moj avto. Izboljšani dodatki v gorivih MOREL učinkovito zmanjšujejo obloge in tako čistijo motor. Z novo generacijo goriv MOREL Evo poskrbite za motor vašega vozila.